Hello everyone. So I'm ready with the class for today's FMGE Sankalp batch. Hope you're all waiting. We were late by 30 minutes. So let's start the class immediately. Good afternoon, Shri. Good afternoon, Subhash. Okay. So let's start with the first question. So this was the first question which was there in your class, right? So this is the 4-year-old child presents with lethargy, irritability, and refusal to walk. On physical examination, the child has petechiae, swollen tender legs. The parents mention that the child has a very limited diet, mainly consisting of milk and cereal. Radiological imaging is ordered to evaluate bone health. Which of the following is a radiological feature of this curvy? So instead of, they have given everything for you. So here what we have to understand is anytime you are answering any question in the exam, uh, think any question. Always look for the clues. So there will be little clues in any question they ask, because if you want to talk about somebody else, so for example, if you want to talk about me, they will tell she was a female orthopedic surgeon. So these are the clues for me, identity. So she used to look fair, she used to have that curly hair, and all those are identities of me. So immediately in your brain you will imagine a person who is a female, who is an orthopedic surgeon, who has a fair and who has that curly hair, like that. So here also, if you want to come to arrive at a diagnosis, each diagnosis will have certain clues. Understood? So here our clues are, very first thing is the child. The age itself is a very big clue for us, right? So age, and then there are certain you can say these are generalized clues such as irritability, lethargy, refusal to walk. So there is some pathology which is happening in the child. And then he has petechiae, swollen tender legs. So the main important clue here is petechiae, right? So petechiae is something which is very peculiar or very characteristic of one particular disease. As you all know, it is scurvy. Yes, Shri, very good. It is answer C, very good. But I want to just evaluate a little bit further for people who are, giving the exam for the first time, or reading about this question first time. And now they have evaluated according to the radiology, and they have come to a conclusion that this is scurvy. But you have to know what are the radiological features of this scurvy. Is fraying and cupping of metaphysis a feature of scurvy? Is widening of growth plate a feature of scurvy? Bowing of diaphysis a feature of scurvy? Or traumafield zone is feature of scurvy? So here, bowing of diaphysis could be a feature, but more specifically, this is the traumafield zone. So whenever we are talking about scurvy, what actually scurvy is? So scurvy actually is a problem in the collagen, right? So there is a deficiency of vitamin C. And what is this vitamin C used for in the bone? So why it is related to bone? What happens is this vitamin C is actually necessary for cross-linking of the collagen. Cross-linking of the collagen. So if you remember, the bone is made up of collagen, that is the organic and inorganic components such as calcium and phosphorus. So when we go back to bone organic structure, so it is made up of organic material and it is made up of inorganic material. So in this, the organic material is nothing but the collagen, and the inorganic material is your calcium and phosphorus. So whenever there is a defect in calcium and phosphorus, it is called rickets. Rickets. So it is the demineralization. So these calcium and phosphorus are the minerals of the bone, and whenever there is a decrease in these minerals, or whenever there is a deformity in the minerals, it is called the demineralization of the bone. That is nothing but your rickets, right? And whenever there is a problem in the collagen, abnormality in the formation of the collagen, because there is a cross-linking of the collagen which makes the collagen very strong. So for this, what we require is, the main ingredient we require is vitamin C. So in scurvy, there is a deficiency of this vitamin C, whereas in rickets, there is a deficiency of this vitamin D, which act as a transport mechanism for calcium in the bones, right? And can somebody tell me what is the disease which is both vitamin C and vitamin D together called as, the deficiency of vitamin C and vitamin D together called as, there is a name for this particular disease? Can you mention that? So sometimes questions come up like this. So we'll be prepared for everything today. 3, I want you to answer for this. Combination of vitamin C and vitamin D together. What is that disease called as? So there is a particular name for that disease. So let me write for you. So the name of the disease is the Barlow's disease. Barlow's disease. So vitamin D, you know it is rickets. Vitamin C, you know it is scurvy. And both together, this is called as Barlow's disease. Fine? Okay. Now I have given few points because let this PDF be a complete revision notes for you. So I have, fine, that's fine. So that is Barlow's disease. No, nothing to feel sorry here. Just remember it is Barlow's disease. Okay, good. So now these are certain changes. I actually don't write or I don't like reading it. So you can revise for your own like this. So there is would be lack of proper collagen formation and there would be easy bruising and bleeding. We have already underlined that there is a petechiae here and then there is a bleeding into the joints and muscles. And one more thing which you have to remember is impaired wound healing, because again vitamin C is responsible for your wound healing. So this topic of vitamin C and vitamin D is usually an integration topic of, it could be from your biochemistry, pediatrics, and orthopedics. So you have to be very, very particular. So whenever somebody is talking about vitamin C, scurvy, just remember that there could be hemorrhage, because again, it is a problem in the vitamin C. The epithelium will get damaged. So that is why there could be some hemorrhages, which are called as perifollicular or subperiosteal hemorrhages. And there could be scobatic rosary. So there is ricketic rosary, there is scobatic rosary. Fine. So these two you have to remember. So whenever somebody is talking about vitamin C, what you will remember first, there will be easy bleeding, that is petechiae and bleeding of gums, and then some hemorrhages, because bleeding is again related to some hemorrhages in the bone. It is subperiosteal hemorrhages and scobatic rosary. And now let us come to the radiological features of scurvy. Very, very, very important. Okay. So now what is that thing? First, we have already we have learned about the subperiosteal hemorrhages. So there will be bleeding in the bone where the periosteum will be lifted. So subperiosteal. So below the periosteum, there would be collection of the fluid. Which fluid? It is blood. So this is called as the subperiosteal hemorrhage. And we already know the problem in this scurvy is because of collagen, right? But the calcium and phosphorus is there very much. So there will be mineralization is always there. So whenever there is mineralization there, that means this calcium and phosphorus is responsible for that whiteness or the density on the X-ray. Right. So whenever there is no calcium in the bone, you feel that the bone is radiolucent. If the calcium is present, you will feel that it is radios-dense. Right. So similarly, if you see this structure of scurvy, you already know that the pathology is collagen. Calcium is always there. So that is why you see there is lot of calcification in case of scurvy. So how do you remember scurvy? Scurvy, we remember that as some calcifications are present. So in rickets, what you see? In rickets, what you see? Rickets, you see all the lucencies because there is an absence of calcium and phosphorus. So minerals are absent there. That is why everything appears dark. In scurvy, everything appears white. So white where it appears. So around the epiphysis, you can see there is a ring-like structure. So this is called as ring epiphysis, right? So there is a name given to it, which is called as Wimberger's sign. So this is Wimberger's sign. There is a calcification around the epiphysis. So this calcium and phosphorus is very happily seen. So there is a ring-like epiphysis, which is called as the Wimberger's sign. And there are some extensions over the metaphysis. The growth plate, this is called the Pelken's spur. This is called as the Pelken's spur. And then you will see There could be a scorbutic zone, which is nothing but as a radiolucent zone here, which is called as the tremor fields zone. So this you have to remember. So there will be calcification, that is called as the dense zone of provisional calcification of white line. Below that, there will be a radiolucent area which is called as the scorbutic zone. This is called as the tremor fields zone. So four important structures I have told you around the joint. So four important structures around the joint, and somewhere you can see subperiosteal ridge at the metaphyseal diaphyseal region. Right, so what are the four zones? The first one is regarding the epiphysis, that is regarding the epiphysis is your Wimberger's sign. So there will be ring epiphysis, that is Wimberger's sign. And then at the metaphyseal zone, you will see there will be a white line of Pankel. Again, because there is a lot of calcium and phosphorus, so there is a zone of provisional calcification. And below that, because the bone is weak here, because of there is lack of collagen, that is called as the scorbutic zone or the tremor field zone. And the extensions over the calcifications are taken as the Pelken's spur. So these are the four important radiological features you have to remember. First for the epiphysis, then for the metaphysis, the radiolucent zone below that, zone of calcification, and the extension. Fine. And one more thing is the subperiosteal hemorrhage. So these are the important radiological features of your scurvy. Right? You're going to remember it. So just whenever somebody is talking about scurvy, first the pathology, collagen, efficiency, cross-linking, then all those generalized features, then the radiological features whenever it comes to ortho. Fine. So these are, again, we have given it in detail for, I've told you, the PDF is made in such a way that you could revise it again and again. I always feel that some of scurvy is little tougher than the rickets. That is why each thing is very much given in clear lines. So you can just go back and, right? And one more thing, the pencil point cortex. So this is also one more interesting feature of this curvy. So the cortex is somewhat pencil point cortex. So it is very thin cortex which you, because again, cortex is made up of bone. Bone weak in collagen. Fine. So that is the base of it. And whenever we talk about the rickets, immediately the friend of the rickets is your scurvy. So we have dealt with scurvy. Now we are going to deal with rickets. So rickets, what is the first thing which you have to remember? The first thing we remember is in this, the bone is fine, but there is weakness of the mineral. So there is a demineralization of the bone where there is decrease in vitamin D levels. Hence, there will be decrease in calcium. Hence, there will be decrease in the phosphorus levels. Okay. So this is what you have to remember about the rickets, and what is the main characteristic thing you have to remember. So because the bone is present but the calcium is not getting deposited, so the first thing what you have to remember is widening of the growth plates. So the growth plate is that area where the bone grows, right? So that is the area where actually the mineralization occurs. And in the growth plate, again, we have various areas. So there are zone of hypertrophy, which is very, very weakest area. So again, after that, you have the zone of provisional calcification. So this area is weak and it appears radiolucent. Hence, there will be widening of the growth plate. And then if you see, there will be three important things, that is fraying, cupping of the metaphysis. So first there will be cupping. What is cup-like structure? So whenever you see the metaphysis, it will be like this. This is called the cupping because there is lack of calcium, right? And fraying is there is extension. Again, like the Pelken's spur, there is extension near the metaphyseal region, which is called as the fraying. So widening, fraying, cupping near the growth plate. And where actually you see for these pictures, so you take the wrist x-rays or you take the knee joint x-rays. So in the wrist joint or the knee joint, you will find all the structures which is called as the fraying, cupping and the widening of the growth plate. And whenever you take the x-rays on the standing view, you can find there would be genu varum or the genu valgum depending upon the age. So there will be genu varum which is bowing or genu valgum which is called the knees, right? And what is wind swept deformity? Wind swept deformity. Somebody can answer wind swept deformity? Yes, very good. Both genu varum and genu valgum. So one knee there is genu varum, and another knee there is genu valgum. So where you see this example of windswept deformity, we are learning it under Rickets. So first example would be Rickets. The second one is second important example where you have to remember windswept deformity. Quicker. So if one knee you see varum, the other knee you see valgum, this is called as the wind-swept deformity, and usually it is seen in the rickets. And then there is one more interesting condition where you see this wind-swept deformity. Quicker. Yes, it is rheumatoid arthritis. So one more condition where you have to remember is the rheumatoid arthritis. Okay, windswept deformity in case of rickets, in case of rheumatoid arthritis. And these are again the rhetoric rosary. As I've told you, the loser zone is usually seen in osteomalacia, not exactly in the rickets. It is usually seen in the osteomalacia. So what is osteomalacia? Osteomalacia is nothing but again whenever there is a vitamin D deficiency in case of adults. Till now I have spoken in case of the children. So whenever there is children, in case of children there is vitamin D deficiency, this results in rickets. But whenever the same vitamin deficiency is seen in adults, you this loser zone or pseudo fracture. Fine. And in children, again, depending upon their age, if they're infants, you see there is a craniotapes and there will be delayed closure of fontanelle. So this is depending upon the age group. Less than 1 year, the fontanelle is closed later. You can see craniotape, that is, you can pinpoint ball like structure. The skull becomes very soft. If this same baby is in the walking age or the toddler age, about to walk, then you see this genu varum or genu valgum depending upon the activity, right? But when you take the x-ray, you will see these particular features, especially the fraying, the cupping and the splaying, and then you see the widening of the groove, right? And obviously osteopenia, because the bone is weak, so there will be weakness of the bone. And rachitic rosary is again, you can see the costochondral junction, they get thickened, so that you can feel as the rosary. Rosary is nothing but the japamala we use, right? So this is called as the rachitic rosary. Similarly, we see this in scobatic rosary also. Fine. So that is about the two important conditions. You read anything or no, but please remember that the rickets and your scurvy is very, very important. So we've completed one very, very major important question. The second one, 65-year-old man presents with bone pain, increased head size and increased hearing loss. So there will be increased head size and the hearing loss, and then this radiographic image shows thickened bone with coarse tuberculations and areas of sclerosis. Which of the following best describes the pathology of Paget's disease? So here what is happening is every time they are giving us the clinical features and at the end they are providing us with the diagnosis. Okay, so whenever we are talking about the Paget's disease, what is actually a Paget's disease? So Paget's disease is nothing but there is some problem in the remodeling. So here you have to understand what is remodeling or what is the dynamics of the bone. So what happens is whenever bone has to form, first there will be osteoblast. They will put the bone, and depending upon the stresses, osteoclast will eat the bone, and again there will be osteoblast which is laying the bone. So there, this is the process. The bone will be laid, and depending upon the stress, the osteoclast will come, eat away that bone which is not necessary, and again the osteoblast will come and put the bone where it is necessary. You understood? So depending upon your stress levels matlab Where you're putting more weight, the bone becomes stronger at that particular area. When you're not putting any weight, then the bone will not be formed in that particular area. So if you see, the femur takes a shape. Femur is not a straight structure like this. It is not like a stick-like structure, but somehow it is like this, right? So why this shape has come to femur? Because of the stress, because of the way we are walking, because of the way we sit, way we stand. Depending upon that, the femur bone is modeled. Depending upon that, the tibia bone is modeled. So how this modeling has appeared? If you see tibia, you see that it is wider over that metaphyseal region, and then it becomes thinner like this, and then it is like this. So this is the tibia. This particular shape of the tibia has come because of this process, which is called as remodeling. So the bone has this very, very important property where the osteoclast will lay the bone, osteoclast will eat the bone. So we have to learn little bit of osteoclast, which is called the giant cells, and this looks like this. And there are multiple cells. It is a multinucleated cell, and there are some uh, uh, what do you say, these structures down there which now releases such an enzymes. Okay, so they release acidases because they have to caspases, and all these enzymes they release, and then they dissolve the bone. So this release of the enzyme is again by the interaction which is called by rank and rank L. So what is rank and rank L? So rank are the structures which are present over the osteoclast, and rank L is the ligand. So always remember, whenever we talk about the osteoclast, so whenever we talk about the osteoclast, you have to remember that there are certain enzymes which are present in the osteoclast, which will cause the degradation of the bone. So bone is dissolved by the osteoclast. Bone is formed by the osteoblast. So this process has to be in continuous dynamic. So there should be formation of the bone, there should be eating of the bone, again there should be formation of, so osteoblast, osteoclast, osteoblast. So this is the thing where the process occurs because of the remodeling, and because of this release of the enzymes and rank L interactions also, this process is there. Some of disturbed with this. Okay, so this why I'm telling you the whole thing is, this is the basic of the remodeling, that is even in the fracture also. Bone remodeling is the final stage, right? So we always say that in case of bone, whenever there is bone fracture, the bone again becomes exactly like its previous one. So exactly it completely heals, and it exactly becomes the way it was before. This phenomenon is called as remodeling. So this particular thing is disturbed in case of Paget's disease. So this remodeling is disturbed in case of Paget's disease. Why it is disturbed? It could be genetics, because of the virus. It could be some mutations which are occurring in the, so but somehow what happens is there is a disturbance in this remodeling. So whenever there is a remodeling disturbance, what happens? So as I've told you, the bone is formed, and now bone should be removed. But if that bone is not removed, what happens is this bone which is formed becomes more dense, and that is as, so this bone which is there is present as a more dense bone, and it could not be eaten by the osteoclast. So it is very, very tougher. This tough bone, do you think it is very much helpful for us? No, it is not helpful. It is a pathogenic bone. Our bone should be strong. It should act according to the stress. So this bone which is formed is just a hardened bone, sclerotic bone. Okay, so now what could be the best describes? So there is a disordered bone remodeling with excessive osteoblastic and osteoclastic activity. I hope this is the right answer. Let's see B and C. Failure of mineralization. So there is no vitamin D deficiency in case of Paget's. Overproduction of growth hormone leading to bone enlargement. So nothing related to the hormones. Osteonecrosis of the femoral head due to disrupted blood supply. No, there would be no disrupted blood supply. There would be no overproduction of hormone. There is some disorder in the bone activity because of the excessive osteoblastic or osteoclastic activity. So in Paget, this is patients. So some phase there will be increased osteoblastic activity. In some phase there will be increased osteoclastic activity. So what happens if there is more osteoblastic activity? As I told you, the bone becomes sclerosed. Sclerosed, and this is one classical example where you can see that the bone is completely sclerosed, right? Actually, the bone should be like this. So this is actual orientation of the bone, right? But here what has happened? So there is complete formation of the bone. What is this called as? What is this important radiological feature which is seen in case of Paget's disease? Quicker, Nitin Kumar Kaushik. Oh, Shri, this is not picture frame vertebra. Picture frame vertebrae, see, picture frame will be like this. So only the ends it will be sclerosed, and in the center it will be lucent. Exactly like the picture frame, right? Yes, this is ivory vertebrae. Very good. A classical example of your Paget's disease is your ivory vertebrae. But picture frame vertebrae is also can also be seen in your Paget's disease, right? So we have dealt with two important vertebral features. One is the ivory vertebrae, one is the picture frame vertebrae. Okay, good. Then what is this? What is this? This is called which appearance of the skull? Very, very classic feature of the Paget's disease again. Yes, very good. This is the cotton wool appearance. The cotton wool appearance of this skull. And again, because of again the sclerotic process, as I told you, seen in the Paget's disease. Yeah, it's there. Then what is this? Some problem with the screen. Yes, yeah. Sorry for that small technical glitch. I don't know. This is the first time I'm facing this problem of, the screen interruption. Maybe time to change my iPad. So now what is this? So we have already dealt that there's a cotton wool appearance. Very good. Sometimes the answers will be visible in the exam also. This one. What is this? This is called as, this is one of the interesting feature. Again, this is the osteoporosis circumscripta. So there will be calcification around the base, around the skull bone. This is called the osteoporosis circumscripta. And now what you have to remember regarding the Paget's disease is, whenever they ask about the Paget's disease, they will first ask you the pathology, that is the bone remodeling, and then there will be certain hints. Again, I've told you, you have to always look for the clues to come to the diagnosis, right? So the first important clue here is, the first, there will be deafness. So patient will have deafness. This is because again there will be sclerosis. So whenever there is sclerosis, there will be narrowing of the cranial nerve foramina. Because of that, there could be some deafness or otosclerosis which can occur. And then you will see there is an increased head size, because the size of the head increases. So that is why there will be increased head size, or whatever, things which they were using before, now these things will become shorter for them. So they will usually complain about, there will be change of the hats frequently, and they cannot hear properly. And usually this disease is seen in 60 years of age, right? So they will present with features such as your cotton wool appearance, and then your ivory vertebrae, and the picture frame vertebrae. Right, so this is about the Paget's disease. So usually they ask you the image-based questions or something like this related to the pathology. Fine. Let's move on to the next one. A 7-year-old boy falls on an outstretched hand and sustained a supracondylar fracture of the humerus. On examination, there is swelling and pain around the elbow. All of the following statements regarding the supracondylar fractures are true except. So please be careful about such words such as except, or which of the following is only true, which of the following is false, like that. Okay. So now, oh, Bharat, very good. Everybody has very answered it quickly. So the answer is radial nerve injury. Then what could be the answer? Which nerve injury is the most common nerve complication, do you think, for supracondylar fracture? Quicker. Now let's mix. Yes, it is the first one, is the anterior introitious nerve more than the median nerve. Then comes the, after AIN and median nerve, it is, yes, AIN. First is AIN, that is the anterior introitious nerve, then median nerve, then the third one could be, yes, ulnar nerve. Very good. So something related to the supracondylar fracture of the humerus. So there are two types of supracondylar fracture of humerus. They could be extension type and the flexion type. Which one is the most common? So according to the classification, usually the supracondylar fracture occurs around the areas of around the years of 4 to 8 years, and there is a classification to it. And which is the most common type? There are two types, I've told you. There's a flexion type and the extension type. Which is the most common? Quicker. Extension type is most common, right? Extension type is most common. And the most common nerve injury we have already discussed, that is anterior introitious nerve more than median nerve. Then what is the most common vessel which is injured here? Yes, Nitin, you're right. The extension type is most common. Then what is the most common vessel? Vascular injury which is related to the supracondylar fracture humerus. Quick. Priya, I want you to answer. Yes, very good. The brachial artery. The brachial artery at the risk whenever you see the supracondylar injury. What is the most common complication of this? Most common complication of the supracondylar fracture humerus. Quicker, Bharat, most common complication. Would not be an immediate complication, but the most common, very good. It is the malunion. So malunion is the most common complication. And what is the deformity we see in this malunion? Nithin, can you answer what is the deformity which we see in this malunion? Very good. It is the gun stalk deformity. Perfect. So these are the features which you have to remember for the supracondylar humerus. So I have told you that this is the 4 to 8 years, and then the most common is the extension type, and the nerve which is seen here damage. These are the complications. The immediate complication could be a nerve damage or a vascular damage, right? So these are the immediate complications which we can expect. And then these are two important things which you have to remember. And the lead complication is a malunion, which is called as the gun stalk deformity or the cubitus. Cubitus. Perfect. So this is about your supracondylar fracture humerus. Now let us just see what is the treatment for the cubitus varus, because you have answered all this really well. I'm just putting forward one more important question. So whenever you want to correct this varus or valgus, this is a deformity, right? So what is the treatment for it? Quicker. I think Bharat can answer this. Very good. It is osteotomy. Very good. Very good. It is osteotomy. So what is that specific name which is given to this particular correction of the osteotomy in case of supracondylar fracture humerus? I was asking, how do you correct varus and valgus? What is the surgery which you do? And Nitin has answered it as osteotomy, but there is one specific name given to that osteotomy. It is distal humerus only, because we have to correct there only, but it is a name. This is called as the French osteotomy. So the correction of the cubitus varus is by the French osteotomy. So now this is the complete picture of your supracondylar humerus. Okay. So as you're very, very perfect in supracondylar, let me also make you analyze about this lateral condylar fracture. So what is this lateral condylar fracture? What is the most important complication of the lateral condylar fracture? When you compare with the supracondylar fracture, here the most common what we thought is malunion, right? And this goes to gunstop deformity and it's treated with osteotomy. In case of lateral condylar fracture humerus, I'm asking. I'm not asking about lateral epicondylitis 3. I'm talking about lateral condylar fracture humerus. What is the most common complication? Yes, cubitus valgus. But how does this valgus appear? I mean, why does this occur? This is because of the valgus is because of here the varus is because of malunion, right? So here the valgus is because of yeah, tardy ulnar palsy is there. Um, Maybe my question is not proper. So what is that late complication which we see? Cubitus valgus is, yes, very good. Shri, very good. Non-union. So in lateral condylar fracture. So why we see non-union in lateral condylar fracture and malunion in supracondylar fracture? Can someone answer this? Nitin? So why lateral condylar is supposed to be a non-union, whereas the supracondylar is going into malunion? Why? Basic anatomical difference. If you see, if you just read the heading only, you will understand. My question is clear? Bharat, is my question clear to you? So distal humerus, we have two fractures we are discussing. One is supracondylar fracture. Then is lateral condylar fracture. What to do with the carrying angle, Bharat? Carrying angle maybe means what to do with that? Because of the carrying angle, there will be valgus and varus. Easy, it is easy. The thing is, the lateral condylar fractures is an intra-articular fracture. So whenever something is intra-articular, the most common complication it is the non-union. Understood? So that is why whenever you see IC fracture, again example of non-union, and whenever you see IT fracture, example of malunion. So whenever there is a joint fractures, whenever something is into the articular area, non intra-articular area. Bharat, you are feeling dull? No problem. You have learned something, right? You should feel happy for learning something, not for answering. Here we are here to gain knowledge, okay? So remember now you are even pretty confident, right? So lateral condylar fracture is an intra-articular fracture. So whenever something is intra-articular, because of the synovial fluid it inhibitors, the growth will not happen. The union does not occur if not treated well. Understood? If it is treated well under surgical guidance, it will get united. But if it is not treated well, it will result in a complication which is called as non-union. And on the other hand, the supracondylar fracture is an extra-articular fracture. Hence, this goes into malunion. So there will be union, but there will be misalignment of the fragments. Hence, this is called as malunion. Understood? Now, here comes the most important question. In which fracture the 3-point bony relationship is disturbed? The 3-point bony relationship disturbed. I'm asking about disturbed. Is it in supracondylar or in lateral condylar? Nitin, ये छोटा डॉक्टर कहाँ से आ गया? Supra. Nitin, is it supra? Think once more. I'm asking about disturbed. The 3-point bony relationship is disturbed. Yes, very good. In supracondylar fracture, it is maintained. Very, very good, Bharat. It is maintained. And in your lateral condylar humerus, it is disturbed. Why it is disturbed and why it is maintained again? Yes, very good. Now, Nitin, very good. Lateral condylar fracture, it is disturbed, right? So, why again it is maintained there and disturbed here? Because 3-point relationship is nothing but the relation between your what? Olecranon, medial epicondyle and lateral epicondyle, right? Terrible triad of elbow? That we'll talk, but let me tell you why this is disturbed and this is maintained. So here what happens is because this is an intra-articular fracture. Intra-articular fracture matlab there will be some disturbance in the condyles, right? So that is why the 3-point relationship is disturbed in case of lateral condylar fracture. And because again this is an extra-articular fracture, so there is no disturbance to the bony structures. And now this fractures occurs above the condyles. तो condyle में कुछ भी disturbance नहीं है. There is no disturbance between the condyles and just it is above the condyles. Hence, the 3-point bony relationship is maintained in case of your supracondylar fracture humerus. It is disturbed in case of your lateral condylar fracture humerus. Is it clear? Now, because Sri has got up this, what is terrible triad of elbow? You should only let us know. Okay. The Chota doctor has given the clearance, so I'm going ahead. Okay. So meanwhile, you type what is lateral terrible triad of elbow. Okay. So now we are done with the fractures around the elbow, that is your supracondylar and lateral condylar. We have learned many important points. You have to remember all those. Supracondylar and lateral condylar. The most important difference is that articular difference. That is the lateral condylar is intra-articular. Okay, supracondylar is extra-articular, just above the condyles. And two important complications. One is vascular. The brachial artery can be injured. The second, the nerve, the anterior interosseous nerve, followed by the median nerve, can be injured. Right? And I have forgot to tell you, because you people are already smart, the lateral condylar humerus, there will be cubitus valgus, and because of this cubitus valgus, there will be stretch of the medial side. There will be stretch on the medial aspect, resulting in the ulnar nerve palsy. So there will be tardy ulnar nerve palsy. What is the meaning of tardy? Tardy का meaning क्या है? As you have all answered, tardy. Oh, Bharat has already gone to next question. Sorry, Bharat, I have to come back just to tell you that Dialana palsy. Because valgus is something this way, right? It is going towards opposite side. The lateral side is getting compressed and the median side will get enlarged. So there will be stretch on the medial side. So medial side of the elbow, near the medial epicondyle, you will find this very, very important structure which is called the ulnar nerve. So whenever there is a stretch of this ulnar nerve, it results in the palsy. So there is a tardy ulnar nerve palsy. So what is this tardy? Tardy, what is the meaning of tardy? Quicker. I think Bharat, you can answer this. What is the meaning of tardy? I'm waiting. Tardive dyskinesia. Okay. Bharat, I'm extremely sorry. I'm not so intelligent as you. So tardy meaning is slow. So what happens is the valgus which develops, it develops valgus, and then there will be slow ulnar palsy. That means whenever there is a cubitus valgus over the years, the patient might have this lateral condylar fracture when he was young, in some maybe 8 years, 9 years, and now as he goes, by the end of 18 years, 19 years, he will find this thing. What is this? What is this? What diagnosis? So at the 18 years of age, the young male will come and show you this, and now you have to tell me what is this. Because I think Nitin, Shri, Bharat can also answer. Claw, very good. So you will see this claw partial hand and pointing index. So this is claw hand. Pointing index will be like this. Sorry, partial claw. Okay, good. I've corrected immediately, so good. So this, you will see this claw hand. Immediately you will ask him the past history. You will ask him, when did you develop this claw hand? And he will say this is has developed over the years. Over the years, there will be a slow ulnar nerve palsy. And now you will go and ask him whether there was any injury in the past to your elbow. Then he will say maybe 8 years, 9 years, 10 years back, when I was small, I had this fracture. And then you go back and see the x-ray, you will find there will be a non-union of the lateral condylar fracture. So this tardy ulnar nerve palsy is nothing but a slow ulnar nerve palsy, which will result in this claw hand. This is called claw hand. Okay, and this is a partial claw hand because of the ulnar nerve palsy. Very good, excellent. Now we have completed the supracondylar and lateral condylar. Very good. Now we'll go back to our question. Which of the following statements about the osteosarcoma is false? Very, very important osteosarcoma, guys. You have to read before going to the exam. So the first one is, it arises from the diaphysis, occurs most common in the second decade, sunburst appearance, treated with neoadjuvant, wide excision followed by adjuvant. I feel this is very, very correct, because we first treat with neoadjuvant, then wide excision. Sunburst is, very classical. Everybody knows. Occurs in second is also correct. So by evaluating each answer, I feel A is wrong, and even if you know the it by knowledge also, A is wrong. So we all know that the osteosarcoma is very, very important question, and I am pretty sure that you will answer again all these questions. So the first and foremost thing, is this malignant or benign? He is using pictures also. Codman's triangle she wants to represent with a triangular thing. So what is osteosarcoma? Is it a benign or malignant? Now quickly answer my questions. Malignant or benign? Very good. The first one is, it is malignant, and this is the most common after your, which is the most common tumor which we see. Most common matlab not everything, not every part of the body. In case of ortho, most common tumor, it is multiple myeloma. Fine. In the bone, in the bone usually we see is multiple myeloma. The second primary matlab completely from the bone which is arising. The most common malignant primary is your osteosarcoma. Okay, and which decades you see this osteosarcoma? Because age is very, very important in case of your oncology, orthopedic oncology. Age is very, very important, right? So which decade we see osteosarcoma is seen in which decade? Decade matlab 1 to 10, 10 to 20, 20 to 30, like that, 10 years. Osh medicos. Total doctor, which decade we see this? Very good. Second decade. That means usually the patient will be from somewhere around 10 to 20 years. Very good. And then osteosarcoma, the area in the bone. Is it from the epi, meta, or the diaphysis? Where we see? Pre, epi, meta, or dia? Very good. Bharat has answered. It is from the meta. Very good. Diaphysis is seen, right? And yeah, the osteosarcoma is associated with the Lee-Fromney syndrome. The association of osteosarcoma is with the Lee-Fromney syndrome. Can you tell me one more tumor which is associated with the Lee-Fromney syndrome? Yeah, very good, Bharat. P53, exactly. One more tumor. So this could be an integrated question with the pathology. So that is why I have put up here. Lee-Fromney syndrome is P53. Very good. What is the one more tumor which we usually see in with the in sync with this osteosarcoma? छोटा डॉक्टर कहाँ गया? Three. One more. So this is usually in sync with the retinoblast. So Lee-Fromney syndrome, retinoblastoma, HP, and CCA. Yes, very good. RB. It is retinoblastoma, Lee-Fromney syndrome. You see this osteosarcoma, right? And this is primary osteosarcoma. When we talk about the secondary osteosarcoma, what could be the examples of secondary osteosarcoma? Secondary osteosarcoma means already the person is having some problem and now it is developing as osteosarcoma. For example, it could be radiation induced. So whenever a person is subjected to radiation, and there could be a development of osteosarcoma. So this is an example of your secondary osteosarcoma. Understood? And for example, your fibrous dysplasia. So these can also turn into your osteosarcoma. Fine. So this is the osteosarcoma, and now I have to tell you what is this. The most important, the radiological finding of osteosarcoma. Quicker. Yes, this is sunburst appear. This sunburst Why do you think this is like sunburst appearance? Atul, why do you think it is sunburst appearance? I mean, so before that, do you think the osteosarcoma is what type of malignancy? Is it a in orthopedics, what happened is these malignant tumors or benign tumors, they can be divided based upon the osteoid forming, cartilage forming, or miscellaneous. So, what type of tumor do you think osteosarcoma is? It is what? It is a cartilage tumor or a bone tumor? Yes, everybody has answered it right. Nitin, KK, Atul, Shri, Bharat, very good. But what do you think? What is the sunburst actually? How does come out? Yes, Chota Doctor now has come up with a very interesting answer that this is the osteoid forming tumor. So they wherever you see on the histopathology also you will see bone on it. So osteoid forming tumor. This is the osteoid forming malignant tumor. Example is osteosarcoma. What is blast? So this osteoid, so what is osteoid? Nothing but your bone. So bone is formed along the capillaries. So this bone is formed along the capillaries, small capillaries. Or if you see, there are some important structures which connects the Hawaiian with the Walkman skin. Right? So there are some important structure. Whenever there is calcification formed along those structures also. So this appears as the sunburst appearance. So this is nothing but all the calcification which is so osteoid forming tumor, right? So that is why it is around the capillary. So that is why the name has given as the sunburst appearance. So this is nothing but the calcification. The osteoid is formed. Now what is this? She has given us the small, what do you say, the emoji here? Codman's triangle. So this is the Codman's triangle. So how this is formed? How the Codman's triangle has formed? So what happens is there will be a lot of bone formation and somewhere near the periosteum now because of this bone formation, this periosteum is getting lifted. So whenever the periosteum is getting lifted, it is seen as a triangle here. So this is the triangle which is formed, hence the name Codman's triangle. But what actually is the Codman's triangle? This is nothing but the elevation of the periosteum. This is the elevation of the periosteum. What is sunburst appearance? Sunburst appearance is nothing but there will be osteoid formation, that is bone formation along the capillaries or certain linear structures. So this is named as your sunburst appearance, both seen in osteosarcoma in the metaphyseal region in the age group of 10 to 20 years. Fine. Now how do you treat it? Treatment is, so first what we do is surgery will be the mainstay. So always we treat it with the excision. So we will remove the tumor. Fine. If it is near the joint, we will remove the joint also and we replace it with some joint replacement and then we follow it by chemo. Radiotherapy is not used. It is a radio-resistant tumor. So we treat it with the chemotherapy. Now, sometimes what happened is if you see the tumor will be extending from here to here. Fine. So if you want to remove this complete one, and then you have to remove this because it is into the joint. Now, to save certain limbs, so always the surgery is between limb salvage or amputation. So do you go for amputation or limb salvage? That depends upon the tumor level. Where is the tumor present? You know how we are operating the tumor. But now, thanks to the chemotherapy, which is called as the neoadjuvant chemotherapy. So what do you mean by neoadjuvant chemotherapy? Come on, type in your answers. What do you mean by neoadjuvant chemotherapy? Sri, Nitin, Bharat, Atul, Chota Doctor, Osh Medicos, where have you gone? Alongside? Adjuvant is something which is accompanying, that is fine. But neoadjuvant, perfect. Bharat Chota Doctor has Given the perfect answer. So sometimes what you do is you give chemotherapy before surgery. So whenever you give this chemotherapy before surgery, what happens is, what happens? Yes, before surgery, what happens? You will downgrade the tumor. This is called as the downgrading and downstaging. So if you remember, whenever there is a tumor, what do? You do according to the grades and stages. So grading is physical, like you see, this is the grade, this is the involvement. Staging is under the microscope, that is histopathological feature. So whenever we give chemotherapy before the surgery, what happens is it comes one grade below, one stage below. That means the aggressive tumor now becomes little less aggressive. So now it bends for surgery, and also followed by chemotherapy, there will be complete removal of the tumor. So that is why we have taken up neoadjuvant chemotherapy, that is before surgery, to downgrade and downstage the tumor, followed by surgery, followed by chemo. Understood? So that is regarding your osteosarcoma. Clear, clear, clear? So that is, we have completed all the points. Fine. Is it clear? Osteosarcoma, any other point we have missed out or any doubts regarding this? Okay, clear, clear. Okay, now quicker. Match it as fast as you can, because this is very, very, very easy. So Colles fracture is something, okay, all are upper limb fractures. Okay, I will write the answer here. You also match accordingly. Colles is fracture involving, I'm done. You, so the answer is, yeah, I have done wrong. P and Bharat, you're making me, check my answers again. So let's see. Let's see together, okay? So the Colles fracture, as we all know, this is nothing but an extra-articular fracture. So whenever we are dealing with the distal radius fracture, you have to remember there are various, types in it. So distal radius fracture, starting with the Colles fracture and the Smith fracture, these two are supposed to be the extra-articular fractures. But what is the difference between them? So the extra-articular fractures, the only difference between them is the angulation. So whenever there is a dorsal angulation and the ventral angulation, so dorsal angulation is Colles, ventral angulation is Smith's. That is the extra-articular fractures. And then when it comes to the intra-articular fracture is the Barton. So whenever there is an intra-articular fracture of the distal radius, it is called as the Barton's fracture. And then the isolated radius styloid fracture. So there are isolated radius styloid fracture. What is the name of this? Can you comment it below? Colles Smith extra-articular, Barton's intra-articular. Bharat, you're right. What is the isolated radius styloid fracture called? Schoffer's, very good. So this is called the Schoffer's fracture. So who are the Schoffer's? What is the meaning of Schoffer? Chauffeurs are the one who drive the car, right? So drivers are called the chauffeurs, and the radius styloid fracture, isolated radius styloid fractures is called the chauffeur's fracture. And now let us see what is dorsal fracture. So this is the extra articular fracture. If you see, this is the distal radius, and this is somewhat away from the joint. So in the textbook, it will give as cortico-cancellous junction. So this is the cancellous bone. This is the cortical bone. The junction of this cortex and the cancel is the weakest area. You always see whenever there is a junction, it is the weakest area, right? So that is why the cortical cancellous junction, this is the Colles fracture. But to call it as Colles fracture, this is not enough. The most important thing is the displacement, the angulation should be on the dorsal aspect. So the dorsal aspect, there should be displacement, there should be or tilt, at least a dorsal tilt, a supination, impaction fractures, dorsal tilt, dorsal angulation. All these terms comes under Colles fracture. So this is the example of your Colles fracture, where you can see there is a dorsal angulation or dorsal tilt. Understood? This is dorsal, right? So this is the dorsum of the hand and this is the ventral aspect of the hand. No confusion. And now same thing, if you see an extra articular fracture here, but here what happens is whenever there is a ventral angulation, whenever there is a ventral tilt, so the bone which has fractured, usually the displacement or the angulation, we talk in terms of the distal fragment. Understood what is distal fragment here? Okay. So this as fractured. So this is the fracture. This is called as the proximal fragment. This is called as the distal fragment. Distal means away. Proximal is towards, right? So this distal fragment, whenever it is moving dorsally or ventrally, based upon that you will tell whether this is a dorsal displacement or the ventral displacement. Here what happened, this particular distal fragment is going dorsally. So hence we are calling this as your Colles fracture. And here what happened, this distal fragment has gone ventrally. So this is your ventral position. So this is your ventral position, right? So hence we call this ventral displacement as your Smith fracture. Everything is same except the displacement and the tilt. Understood? Do Colles and Smith. Now what happens is the intra-articular fracture. So if the fracture is extending inside the joint, so this is the intra-articular fracture, which is called as the Barton's fracture. Intra-articular fracture. It is extending into the joint, is intra-articular. Whenever it is extra-articular, it is Colles or Smith. Whenever it is inside the joint, it is intra-articular Barton's fracture. Clear? Very good. So now we have understood these three very, very important fractures. Schoffer's fracture is nothing to worry. So you identified this styloid fracture. I'll just make you. Here it will be clear. So Schoffer's fracture is nothing to worry. This, so only this particular fracture, this isolated radial styloid is your Schoffer's fracture. So this is all clear for us. So we are perfect with this. So now nothing to worry, right? Colles is dorsal angulation. So 1 is E. I am right. Smith is volar angulation. 2 is D. I am right again. Barton's is intra-articular B. So all the three are correct. Now let us learn about the Monteggia and the Galeazzi fracture. So these are the two important forearm fractures. So those are the wrist fractures. These are the forearm fractures. We have two important things. One is called the Monteggia fracture. The second one is called the Galeazzi fracture. Galeazzi fracture. So let us understand the difference between them. So as I've told you, it is a fracture of the forearm. So we all know that the forearm has two important bones. So what are the forearm bones? One is called the very important radius. Second one is the ulnar. So these two are the forearm bones. So they should be fractured in these two. Hence they are called as forearm fractures. But these two fractures are not just fractures, but these are fracture dislocations. Now tell me, what is dislocation? What is dislocation? Quick, quick, quick. Fracture is break in the bone. What is dislocation? Atul, what is dislocation? Or out of not position. Some Germany, bone out of joint cavity. Bone out of joint cavity. Bharat, too complex, Bharat, you are. What is bone out of joint cavity? So this dislocation is nothing but they will be now. Okay, so there is a joint. Joint is always between two articulating surface, right? How is a joint formed? Two articulating surface. So whenever there is no connection between the articulating surfaces, so the contact between the articulating surfaces is lost, then it is called as dislocation, not position change. So now this is your, imagine now this is your glenoid cavity. And now this is your humeral head. So this is a joint. So humeral head and this is, sorry, glenoid cavity and this is the humeral head. Now this humeral head is sitting nicely into the cavity. Right now what happens? Dislocation का मतलब क्या है? ये एक articulating surface है. ये glenoid का articulating surface है. ये humeral head का articulating surface है. So whenever these two are in contact, there is a joint. So there will be movement of the joint. Now what happens? Dislocation is this contact has been gone between the two articulating surfaces. So this is the dislocation. When there is some contact between the articulating surfaces, what is it called? Absolute no contact between the articulating surfaces. Yes, Atul, you're right. Coming out of articulation is the dislocation. But now I'm telling there is some contact between the articulating surfaces. Now what is this called? The some contact is called as, joint. Bharat, tell something you will tell, no? Tardive dyskinesia, something like that. Atul, please help us. Some contact is there. Shri, you stopped answering because some contact is called what? Subluxation. This is called as subluxation. So whenever somebody is talking incomplete, very good, Chota Doctor, incomplete hai. But what is the terminology given to that incomplete? That is subluxation. So complete loss of the articulation is dislocation. Some loss of articulation is subluxation. Understood? Clear, everybody? So now what I'm trying to tell you is there are certain forearm fracture dislocations. The name given to them are, one is your very important Montigia, the second one is your Galeazzi fracture. Now let us see what is this fracture dislocation in case of Montigia. So whenever we are talking about the Montigia, we should remember that this is the fracture of the ulnar bone. There is a fracture of the ulnar bone with the radial head dislocation. So one fracture, one dislocation. So one bone there is a fracture. So other bone there should be dislocation, right? So here what happened? There is a fracture of the ulnar bone and now the radial head is getting dislocated. So this radial head is present in the proximal joint. So in the forearm we have two. One is proximal radioulnar joint. The second one is a distal radioulnar joint. You remember forearm bones, how they are formed? So one is the radius. The second one is the ulnar. And what you have to remember is there are two important joints, the proximal radioulnar joint and the distal radioulnar joint. And if you still want to learn something new, there is this important membrane which is called as the interosseous membrane. Interosseous का मतलब क्या है? In between two bones, that is your radius and the ulnar. So this is your radius and this is your ulnar. Understood? So these two joints. So one fracture, one joint will be disturbed. So in case of Montigia, what did I tell you? There will be fracture of the ulna somewhere here. The proximal radio-ulnar joint will get disturbed. That is what? The radial head. The radial head will get displaced. So see, if you see, the radial head actually should sit here nicely. It should sit here. Right? Now what happened? It is getting displaced. So this is the example of your Montigia fracture. Not to miss. So this is the very important thing. So here I just want to clarify one thing. So whenever we take the X-rays of the forearm, right? We are taking the X-rays of the forearm. And what actually we write? We'll just write, give us the X-ray, forearm, AP and lateral. And now we will get this particular X-ray like this. Fine. So sometimes we might miss the radial head dislocation. So that is why what we have to always do is one joint above and one joint below should always be examined in case of any fracture, not only forearm fractures. Even if you're dealing with the femur fractures, you're dealing with the tibia fractures, you should always examine one joint above, one joint below, and you should be very careful whenever you're dealing with the forearm fractures in particular, because we have very great entities here. One is your Montigia fracture, the second one is your Galeazzi fracture. So that is why in orthopedics we deal with two views, AP and lateral, two joints, one joint above, one joint below. Understood? So this is the Montigia. Now we have understood Montigia clearly. So where now the Galeazzi will become very easy. Now Galeazzi, what is this? So this is the fracture of the radius. So opposite to Montigia. Montigia it was fracture of the ulna. Now in the Galeazzi it is fracture of the radius. In the Montigia it is PRUJ, that is proximal radio-ulnar joint. In the Galeazzi, it is distal radio-ulnar joint. So this is your distal radio-ulnar joint. So if you see, the ulna has changed its variance here and it has moved, you can see the dorsally. So there's a fracture radius with some disruption in the distal radio-ulnar joint is a classical example of Galeazzi fracture. Understood? Where have you gone? My Bharat, Atul, Sri, Nitin. Understood? Montigia and Galeazzi? Chota doctor, very good. Nitin, Bharat, Atul, Sri. So now get back to this question. So here Montigia, what we fracture of the ulna is Montigia with radial head. So 4 is AM right here also. 5 Galeazzi is radius with distal radio-ulnar joint. See, so we are right. D is the answer. Now let me go back to this chart and see who have answered it wrong. I am right only after 10 years of experience. You are still so young. So nothing to worry about it. Over a period of time, you will also become right. Okay. So now this is see now I have explained so much about Montigia and Galeazzi, but in the exam you tend to get confused. So remember one thing. Montigia is M and medial side ulna. Understood? Remember only this. Montigia M, medial side is ulna. And whenever there is an ulna fracture, there should be radius involvement. So remember that this is the radial head. Now don't try to remember Galeazzi. Remember one so that you will not get confused in the exam. M, Montigia for the medial side. That is your ulna. So ulna radius. Okay. And in the radius, what happens is the radial head. So radial head is proximal side. We all know that. So remember only these three things. So Galeazzi will automatically fall into place. Understood? Okay. Now we have finished this. So this is very important, guys. It will be asked in any form. So they can ask only about Colles, Smith, or Barton's, Montigia, Galeazzi. We have finished almost, 5 to 6 questions in one question. Fine. Now going back to the next one. The 14-year-old The 14-year-old boy presents with localized pain and swelling in the right femur along with fever, weight loss. So these are again the clues. We have to check for these clues always. So there is a 14-year-old boy, localized pain and swelling in the femur. So there is a fever. So first time whenever we see fever, we always tend to go for infections, right? So infections usually present with fever. And weight loss. So weight loss, again, you have to be very, very careful because whenever we read about weight loss, weight loss. So what are the two important things which your mind should strike with? So whenever your relatives or friends or somebody is telling there is a significant weight loss, probably 10% of weight in 3 months, which is very, very significant. Bharat has jumped into the answer B. Very good, Chota Doctor. Very good. I'm very, very impressed. So, whenever somebody talks about the cancer and tuberculosis, the most important things which you have to remember is their weight loss. So, in case of cancer, in case of tuberculosis, these two are the two important diagnoses. Remember it clinically also. You have to always think about these two things, cancer and TB. Fine. Now we have done with fever. So there is an infection and there is a weight loss. Radiograph imaging shows lytic with onion skin appearance. So this is very easy. Whenever somebody talks about the onion skin, we know it is about the Ewing's sarcoma, right? It is about Ewing's sarcoma. Now let us see what all has been given regarding that. It primarily occurs in the older adults. So Ewing's also there is some 10 to 20 years decade. Okay, older adults ka matlab maybe is in talking about 30, 35, something like that. Ewing sarcoma is associated with a specific translocation involving chromosomes 8 and 21. It typically has good prognosis without treatment. Ewing sarcoma is a malignant bone tumor. Which of the following statements about the Ewing sarcoma is right? So the most important thing here is it is not a malignant bone tumor. So Ewing sarcoma is a tumor of what? Which cells are getting involved here? And it is usually the translocation between 11 and 22, 8 and 11 and 22. So what are the type of cells here? Okay, let's talk about the Ewing's sarcoma. So the first and foremost thing what I want to tell you about is it is a neuroectodermal tumor. PNET group, okay, group of tumor. Okay, this is very, very important, which you have to remember. And then it also occurs in the age group of 10 to 20 years. The most important thing, as we have already mentioned, is the diaphysis. Very good, Bharat. It is diaphysis, home of right, osteoclast. Who? That is true. What is osteoclast? It is true. That is small round blue cell tumor is correct. So this belongs to a group of small round cells which are blue in color, like your medulloblastoma, something like that. Okay. So this is about the typical features of the Ewing sarcoma. Okay. And then what else we have to and most important is your onion peel, onion peel, onion peel appearance. But here, what I am, yes, it's the most radiosensitive tumor, right? Yes, right. You are right. But radiotherapy is not used for it. It has no good prognosis. It's not very good prognosis. So one thing what I want to clear here is Ewing sarcoma, it presents with the fever and pain. And we tend to think this as infection. But in ortho, every tissue you send for culture sensitivity thinking it as infection, you have to send it for biopsy also, because of this dreadful cancer which can mimic as infection sometimes. It can which can mimic as infection sometimes. So that is Ewing sarcoma, very, very, very important. So whenever you're thinking it as Ewing sarcoma, but you should also send it for culture and sensitivity along with the biopsy, because sometimes you might think it as Ewing sarcoma, but it turns out as an infection. So this is a very, very important tumor which you have to differentiate between infection and the tumor, because everything falls in the same category. Like it presents with fever, right? And it occurs in the age group of 10 to 20 years. And again, they will be raised in the ESR, and they will be raised in the CRP, and they will be raised in the WBC count also. So everything appears as the infection, right? But what is the one thing which you take the X-ray whenever you take it? The lesion appears in the diaphyseal region, and you can see the periosteal reaction as the onion peel appearance. And this is supposed to be the most radiosensitive uh, tumor, and it melts like snow on radiation. Melts like snow on the radiation. And the prognosis depends upon certain risk factor like the presence of fever, increase in the ESR, and various other, whenever they present with a lot of, other things, the prognosis depends, or there are particular list which you have to remember depending upon the prognosis. And one more thing, it is radiosensitive, but usually we treat it with the surgery and chemotherapy. We don't tend to use radiation because radiation induced osteosarcoma will be a risk for it. Is that fine? So these are about all your Ewing sarcoma. Usually what they ask you about this onion peel appearance, the peanut cells, and the translocation, that is between 11 and 22 chromosomal translocation. So this is about your Ewing's sarcoma. Okay? Any doubts? Clear? Now this is what you have to answer. This is very, very important. So 25-year-old woman presents with persistent knee pain, swelling for several months, lytic bone lesion located in the distal femur, which appears subarticular. Which of the following statements about the giant cell tumor is false? Giant cell tumor is very, very, very important. And now you're going to tell me everything about the giant cell tumor. Quickly, each one point, starting with Shri. The first thing what I want to ask is location. Location, Sri? Not the answer. No, I want the location. That is radiology. Location of GCT. Whenever I tell you location, that means epimeta. Very good. It is epiphyseal in location. Very, very good. Whenever somebody says it is epiphyseal in location, it means subarticular also. Be very, very careful with the wordings, because this is a tumor which encroaches the joint but will never cross the joint. Understood? It is like kissing the joint. It goes and kisses the joint, okay, but it will never cross the joint. So very, very important regarding the GCT is its location. So the location is epiphyseal. Now what is the pathology here, Nitin? The pathology lies in which cells? Diaphysis to physeal. No, remember please, this is epiphysis. That's it. No confusion. Very good, very good. Bharat has gone, always Bharat will be one step ahead, rank ligand in osteoclast. Very good. Nitin, thanks for that. It is a giant cell tumor osteoclast, but please also remember that there is some confusion between the origin of the cell in case of giant. Okay, some schools teach that this is osteoclast, but there is also some schools or some researchers, they say there is nothing to do with the osteoclast. Okay, next, on biopsy, what do you see? Biopsy, two interesting things what you see on biopsy. uh Atul, can you answer this? Yes, one is the giant cells which we see, and the second one is Atul. One is the giant cells we see, the second one what we see? So the question is open to all. Nitin, Bharat, Kiran, Jyot, Ihu, Sri, some Japanese or Russian, I don't. Wakha, Pai, something. Huh. Jain cells. And faster, there are 65 questions we need to solve when we are still somewhere in maybe 8 or 9. Nucleolayer. No, those are called the mononuclear cells. Very, very characteristic feature of the giant cells is what you see is multiple mononuclear cells. So there are multiple mononuclear cells, and in between these mononuclear cells, what you see is amalgamation of all these nuclear cells, which results in what is called as the giant cells. So you see there are giant cells in between ocean of the mononuclear cells. So this is the typical biopsy picture which you see. So there are numerous, like this, numerous mononuclear cells are there, all in your blue color and the pink color with the giant cell. So this is a typical biopsy picture which you have to remember, because in the exam there is an integrated questions, right? So they will put up only the biopsy in integration with the pathology. They will tell this is the HPE, and now we have to identify the tumor. So now we will identify the tumor because they have given at this is the epiphyseal location and usually seen in the second decade, that is 20 to 40 years of age. 20 to 40 years of age, and this is supposed to be a, do you think this is a benign or a malignant? Giant cell tumor, is this a benign or a malignant tumor? Which category do you put this? Quicker, quicker. I want Shri to answer this. Benign. Okay, Pihu has gone for benign. Kiran Jyot has gone for benign. Shri has gone for malignant. Oh, my baby. Why malignant? Athul, benign. Nitin? Sota doctor has gone for malignant with spelling wrong. Okay, that's accepted. Then Nitin. That's fine. That's fine. Nitin. Ah, very good. The answer has come up. It is benign aggressive. Very good. So this is not a benign, this is not a malignant, but this is benign aggressive. Can you explain why this is benign aggressive? Yes, Shri, good. It is locally aggressive. What do you mean by that aggressive component? It's common. What do you mean by aggressive? Why? Why are you not putting it in the benign? Why are you not putting in the malignant? But you have given a special term coined as benign aggressive. What do you mean by this aggressive nature? Very good. I'm so impressed, Atul. It can recur. So the most important thing is excuse me for the spelling. The most important thing I want you to remember for the giant cell tumor is its recurrence. So it is a recurrent tumor. Even if you treat it completely, there is always a chance of its recurrence. So that is why this is called as a benign aggressive tumor. There is no metastasis. There is no metastasis. It is a benign tumor. It is limited to its boundary. It obeys all the benign rules and regulations, but this is an expansile tumor. It is an expansile eccentric tumor. Eccentric ka matlab, what is eccentric? Eccentric is something outward, there doesn't stay in the center. They are, something different at the end of the thing. So there are extra expansile, extrinsic, epiphyseal in location, and they are benign aggressive tumor. So these are all the things, these are, yes, away from the center. These are all the things which describes your giant cell tumor. And the most important thing is there are these trabeculations which you can see. These are the trabeculations inside the tumor, and this gives a appearance which is called as the soap bubble appearance on the x-ray. This is the soap bubble appearance on the x-ray. Eggshell crackling is okay. See, that is not usually, we don't see it, it is just for that mnemonic they have put up. Eggshell crackling is huge tumor. That tumor has to be so huge and you have to touch it and then you have to feel it. So that is not so important for you to remember. But remember, this is epiphyseal, expansile, and eccentric. Why do you want to remember this eccentric and expansile? So you have to differentiate it from the other cystic like lesion. So this is a cyst like lesion, right? It is a lytic. Lytic ka matlab, you see all the darkness. So whenever we see dark, it is lysis. Whenever you see white, it is sclerosis. Understood? Sclerosis means there is lot of whiteness, or there is lot of bone which is formed there. Hence it is called sclerotic bone, which is dense bone. Lytic is weak bone. So whenever you see a lytic lesions with the trabeculations, and it is, huge. What do you mean by expansile? How do you tell this is expansile? How? So what you tell is, so now see, this is the growth plate, right? So this is your margin. So this is your margin of the bone. Now when you draw this particular margin at the tumor level, you can see it has been expanded. So when you compare this with this and this with this, so now you say this is expansile lesion. So it is increasing in the breadth. Understood? So that is the meaning of the expansile. So expansile, eccentric is at towards the end, not in the center. Epiphysis, this is the region called the epiphysis, near to the joint, encroaching over the joint. Understood? And this is very much a lytic lesion, and this gives appearance which is soap bubble appearance. And now what you do? How do you treat it? Treatment of the giant cell tumor, very, very important. So we know this is a benign tumor. So whenever something is benign, what you do? We just try to remove it because it is not spreading anywhere. We just try to remove it. But we have given a tag to it, that is, it is aggressive. So aggressive ka matlab kya hai? What we have learned aggressiveness is nothing but the recurrence part. So how do we avoid recurrence? So to avoid this recurrent, we do what is called as extensive curettage. Okay. Yeah. This is removing is nothing but it is called as curettage. Curettage means you will nightly scrape off everything you scrape off. This is called not extensive but extended curettage. Okay, you do extensive only. Extensive, extended curettage. What do you mean by extended? मतलब क्या है extended का मतलब? What is that meaning of extended? Your right street is extensively you do curettage. Extended curettage pihu. Also taking out normal margin. Okay. We took out the normal margin. Okay. How do you know it is normal margin or not on the surgery? We will never know, right? On the surgery, how will you know? That margins only we can see under the microscope. But here we'll do something to be assured that we have, done something for the normal also. In marrow, they have told of extensive. Hey, okay, extensive curettage is there. I am not denying the fact. The curettage is done as extensively. No, the answer here is extended curettage. Extensive is not the word. Extended curettage. You can do curettage extensively. I mean, excessively, not extensive curettage. I am not sure of the word extensive. The word what I have learned is extended curettage. Okay? Okay, now it's okay. Whatever it is, extensive or extended, it's okay, fine. What is the meaning of it? Meaning of it is we use certain adjuvants. Plus, we do curettage. What are these adjuvants? Thank you so much for going with me. So what are these adjuvants? These adjuvant can be liquid nitrogen or it could be bone cement, right? Yes, very good. Phenol. Now, why are we putting these adjuvants? So, what all these do, they will kill the tumor. So as Pihu has told us, we have to take out the normal margin also. So on the surgery, we doesn't know what is normal, what is curettage. Now what we'll do. So for example, now what we'll do is we go to this particular patient. Now we will incise and we will go up to the joint. I mean, like we'll go up to the radius, and there will always be a small window there because it is a very light tick. It's very papery thin, right? Even if you touch with the scissors also, the whatever the bone is there, the over that bone will come out. And now what we do, we take a curette. It's called the bone curette, and we dig everything what is there. The everything what is there is nothing but the tumor, right? The tumor will be something like the slimy layer, slime. The kids play with the slime, no? It will be like that. So all the curettage we do, that curette we take and we do everything. We curette neatly so that some hollow is there, some space is there. Now what we do is we take this liquid nitrogen or bone cement or phenol, anything can be used, and we fill the cavity with this liquid nitrogen or bone phenol. Now, because of this, instead, see, now bone cement is safer to use, right? Bone cement, what it will do, it will produce heat. Now, this heat will try to kill the tumor and it will prevent the recurrence. It will prevent the recurrence. That is why we do what is called as extended curettage. Curettage ka extension version. What is the extension version of the curettage? We are putting this adjuvants, right? So, extensive curettage is we extensively remove all the things, right? We don't take any chance because there is a high chance of recurrence. No, whatever is there we try to remove. So that is extensive removal of the contents. But extended curettage is the terminology given to the addition of the adjuvants after curating. Understood? So the treatment is extended curettage. Okay, everything is to prevent this recurrence. Everything is to prevent this recurrence. And I want to add one more thing. Now, denosumab, you have heard denosumab. As somebody has answered, Bharat has answered that rank ligand in osteoclast. He has answered that beautifully because now they have targeted this rank ligand in case of osteoclast in treatment of the giant cell tumor. So they have included denosumab as a treatment. Okay, not completely denosumab. They will give doses of denosumab, some 120 mg, something like that, for 4 to 5 weeks so that the size of the GCT will get decreased, and after that they will do this extended curettage. Now this is under the trial. I'm just giving you a little bit of information because they might ask you, as you know, a research question or a new question, something like that. So one drug which is useful for GCT is your denosumab, again related to the rank L. Yes, very good. Monoclonal antibody against the Rankel. Very good. Bharat and Pihu, excellent. So that is the answer for this, the denosumab. So now that completes the GCT. Everything perfect? Anything we have missed out? Yes, denosumab is obviously used in osteoporosis also. Okay, you want to differentiate it from the ABC. So ABC is what? ABC is your aneurysmal bone cyst, right? So this is your aneurysmal bone cyst. So what do you mean by aneurysm? Aneurysm is something which is blood filled, right? This is a blood filled bone cavity. This is also lytic, this is also there, but this is mainly from the metaphysis. ABC is mainly from the metaphysis, but you see GCT is mainly from the epiphysis. So whenever you take the x-ray, you can be pretty sure that between ABC and your GCT. And GCT, what happens is there is a typical soap bubble appearance, which usually we don't see with the ABC. And we only don't rely on MRI. Rasi, rely on X-ray, right? We go for MRI also. On the MRI for the ABC, you feel something like the fluid filled cyst. So multiple fluid levels are seen in case of your ABC. right? That is how usually we differentiate, okay? Yes, yes, that is one more important thing. Very good, Shri. You have taken up. See, I have told you the age group is 20 to 40 years. So, whenever there is an epiphyseal tumor which occurs after the closure of the growth plate, so after 20 years, usually the growth plate closes, right? So, that is why we never see before 20 years. Only after the closure of the growth plate, we see it. But the main thing which you have to differentiate is you go for MRI. So these are all the cancers, right? This is the oncology, right? So always we have to go for the higher investigation. It is not like you learn about, you take X-ray, you see subabule appearance, and then you say GCT and then you treat it. It is never like that. In clinical practice, in real scenario, what happens is you always go for the higher investigation. Yes, for MRI and and then you have to evaluate completely in detail. So when you finish all the investigations, then you start the treatment, and usually these are all confirmed by the biopsy. Understood? So the one thing which you have to look for is the location. So ABC is mainly from the metaphyse, but remember the ABC is also an expansile lesion. But where you see GCT is somewhat encroaching the joint. Understood? And MRI, it is multiple fluid levels which you see in ABC, whereas in GCT you don't see any fluid levels. Understood? Yes, thank you, Pihu, for that. Okay, next one. A 3-year-old child is diagnosed with the CTV. Very, very interesting. CTEV, commonly called as Clubfoot. What is the most appropriate initial treatment? Come on, quicker. Nitin, Bharat. What is the answer? Yes, very good. Ponseti, very good, very good, excellent. When you do it, Ponseti, very good. So we don't go for surgery immediately, right? We go for bracing with foot abduction orthosis or physical therapy. But before answering, my dear kids, my dear children, you should always look for the age. Very good. We should always look for the age. If it is a newborn, if it is less than 1 year, you directly go for treatment with Ponseti. 3 years is the age where baby has already started walking. So still you want to go with Ponseti or you want to change your answer? Chemistry. Bharat will always come with some fancy terminologies. Chemistry posterior medial soft tissue release. Okay, Shri, soft tissue release. Within, want to change something? Pihu, want to change something? Okay, let me clear this for you. So, what happened here is the 3-year-old child or a 2-year-old child or a 1-year-old child, anybody presenting for the first time, you will always go with the cast. So, we will always try the cast method. So, we will always go for casting with Ponseti method. This is just a trial. You will clearly explain the parents that this, as you have bought this, is a 3-year-old child, where we can't start the treatment as we have done for the newborn, but still we have to give a trial of Ponseti. It is not that directly you go for some surgical releases. You will go for a Ponseti method first, and then you will go for your posterior medial soft tissue release. Okay, so the answer still will be casting using the Ponseti's method. Is that clear? Clear, clear? Very good. We will learn regarding CTV. I will teach you. There is one more question coming up. Then there we'll discuss regarding CTV. Okay, which of the following is false about ankylosing spondylitis? One more important, very, 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 very important, very, very important. Ankylosing spondylitis. It has an extra-intestinal manifestation of ulcerative colitis. Pain worsens in the evening and on exercises improve the rest. Okay, pain worsens in the evening and exercises improves on rest. Okay. Erosion of the sacroiliac joint is the earliest sign in X-ray finding associated with HLA-B27. Okay, we all know that ankylosing spondylitis is a one condition which is associated with HLA-B27, and we all know that it is mostly seen in young males, right? And what are the presenting symptoms? How do they present? The classical presentation of ankylosing spondylitis. How do they present? One word. Bamboo spina. Presentation to the OPD, Chota doctor. I mean, what are the complaints of the patient? Early morning stiffness, very good. So they usually present with the early morning stiffness and low backache, very good. They present with low backache, which is very, very severe as they get up in the morning. That is after rest. Here lies the trick. So whenever something is present after rest, that is an inflammatory condition. Understood? So you have to always differentiate between whether this is an infective, right, generative, or inflammatory for the joints. So whether you have to know it is an infective joint or degenerative joint or inflammatory joint. So here lies your what do you say, the knowledge. So first the step is you have to differentiate between these three. So how will you differentiate any joint? If they present with fever, pain, you go for infection as usual. If they present with the degeneration and inflammation, how will you know? Because both they will not have fever. So what is the most important thing which you have to ask for degenerative and inflammation? Bharat, how do you differentiate between degenerative and inflammation? Age. Okay, let us take 50, 40 years, somewhere in between. So I will give you, okay, 1 point for age. Okay. Decreased joint space in OA. See, that is after X-ray on the, once a patient comes, you will see it clinically. Clinically what diagnosis you will put. Very good. Chota doctor is right now. He improves with rest and aggravates. Very good. Now we will ask them, when are you experiencing this pain? Because both degenerative and inflammation will tell you that they have pain. Whether it improves with rest or aggravates with rest. So for that, how will you tell? You can't confuse the patient, right? They will ask, you will take rest and then the pain comes, or what will happen? So simply you will ask them whether there is morning stiffness or not. So whenever somebody is telling after rest, that means night full they will take rest, no. And then morning they come with pain. So that is why the term morning stiffness has been given. That means inflammation is after rest. So whenever somebody says that there is a problem in us after, in the morning main, whenever there is pain more in the morning time, then it is inflammation. Degeneration is usage, excessive usage. So we get up in the morning happily, no pain, nothing. Then we use our knee joints. Then at the end of the day, if they have pain at the end of the day, then that is degeneration. That means excessive usage. They are using it and now they are having pain. So that is because of degeneration. Understood? You go back and you ask your mother or father if they're having osteoarthritis, or your grandmother. You ask her when is the pain. Usually osteoarthritis they will tell at the end, in the evening, in the afternoon, once they work and they sit, then they feel this pain. But inflammatory, as soon as they get up, they take a complete rest whole night, they put their hands like this, and the morning they see there is a swelling of the joints. They get swelling of the joints and they can't move the joint, becomes because all the inflammatory particles will settle there and they cause irritation of the joints, causing swelling of the joint. And once they start moving the joints in the morning, so half an hour, what they do, they try to move their joints, they try to do this and that, and then once they move the joints and once they try to be active, the pain gets subside because all the inflammatory things they get washed out and the pain gets subside. So that is the difference between the inflammation and the degenerative and the infective. Is this clear? Okay. So the as I've told you that this is the inflammation. So ankylosing spondylitis also what happens. So the name itself is ankylosing spondylitis. Spondy means nothing but spine. Itis means inflammation. So spine getting inflamed. So this is an inflammatory condition which is seen in the spine. So what happens is low backache. The patient will have low backache. Why low back ache in particular? Because spine is present from the cervix, from the cervical joint to the lumbar joint, because there is the involvement of the specific joint, that is the sacroiliac joint. So because of the involvement of the sacroiliac joint, because this ankylosing spondylitis antigens, they like the sacroiliac joint so much, they will irritate this joint and then they enter into the lumbar joint. So because of that, the patient will have this low back ache and it is more in the morning. Again, I've told you the reason why more in the morning, and now the patient comes, get ups, do all the exercises, and now the pain gets relieved. Understood? This happens over a period of time, probably from 25 to 30 years. Once he has entered 30 years, what happens is there are extra manifestations such as pulmonary complications. He will have heart problems, he will have like carditis, or he will have eye problems such as uveitis, right? So these are extra manifestations, extra bony manifestations he will have. That means other than bone, so other than joints pain, he will have enthesitis. What is this enthesitis? Enthesis is the point where the tendon or the tendon gets attached to the muscle. For example, if this is your calcaneum bone, the Achilles tendon will get attached here to the bone, right? So this point of attachment of the tendon to the bone is called as enthesis. And all these areas he will have inflammation, so this is called enthesitis. So he will have pain over there, here, everywhere. He keeps on telling us the pain. Now what you do, now he will come to your OPD. Coming to the OPD, now what you do, as you're very very intelligent doctors, you will, as you see that this is the age of somewhere, young male, and because he's telling all low backache and all, because you all learned so much of the uh, ankylosing spondylitis, you will immediately think, okay, this could be ankylosing spondylitis, and now you want to test for your sacroiliac joint first. So what is that one test which will tell you that the involvement of SI joint is there? So this is the test, that is the Faber. So you will do figure of 4, or the flexion, abduction, external rotation. And now what you do, you will just try to disengage the two pelvis. So you will press the, see, two uh, hand. So one hand on the thigh like this, and second hand on the opposite. So you will try to distract the pelvis. So whenever you're trying to distract the pelvis, the sacroiliac joint will be more painful. So once the patient is having pain on this test, which is called the Faber's test, then you can confirm that there is an involvement of the sacroiliac joint. Understood? So this is the one test for sacroiliac joint, and there is one more which is called the pump handle test and Ganselin's test. Similar, all same, different maneuvers. So pump handle is, you will try it opposite, this knee touching the opposite shoulder, something like that. And Ganslin's, again, opposite leg is extended. You can go back and read these two tests. So these two tests we will do. Getting it? I'm coming to the Schober's weight. So these two are for the sacroiliac joint. Okay. Now I have told you ankylosing spondylitis is what? Ankylosing. What do you mean by ankylosis? What do you mean by ankylosis? Ankylosis is bending. See, it's fusion. Then what is arthrodesis? Opening and okay, Chota doctor has given me the answer. That's fused ankylosis. So now what happened? The spine is getting inflamed and it is getting fused. Before that, I want to tell joining arthrodesis is okay. Okay, yeah, you're right. Arthrodesis is joining what? Arthrodesis is what? Joining of two. Joining is between always two things, right? What are the two things? Nitin, stop the answer. Bharat, KK, where have you gone? Athul, Kiranjot, two bones in a joint. Okay. You can be more clear, right? Two articulating surfaces. Okay. Joining two articulating surfaces. That means there is no movement in the joint. Arthrodesis is surgical fusion. Surgical fusion of the two articulating surfaces. For example, there is some problem in the ankle joint. So the two articulating surfaces of the ankle, will fuse it together. We will put some plate or some wires around the joint and we'll fuse it. So this is called surgical fusion. Arthrodesis, whenever it is pathological fusion, it is ankylosis. So whenever you're talking about something pathological fusion, it is ankylosis. Whenever it is surgical fusion, when the surgeon is fusing, it is called arthrodesis. Okay, so the ankylosing spondylitis is the pathological fusion of the inflamed spine, right? So now over a period of time, what happens is there will be formation of syndesmophytes. So what do you mean by syndesmophytes? So these are nothing but osteophytes in spine. You know about osteophytes, the extra growth. So extra growth, whenever they form in the spine, they form at these ends and they fuse the two vertebrae up and down, resulting in what is called as the bamboo spine. So complete fusion of the spine is called as the bamboo spine. Understood? So whenever such a fusion occurs, there will be no movement in the spine. So this can be detailedly known by the Schober's test. So Schober's test is nothing but you will mark a point here, right? And you will mark another point here, and now you'll try to measure it. And on the bending, usually the point where you have marked this point and this point should increase, right? So on bending, it increases. But in Schober's test, there will be no increase in the points. That means there is no movement, there is no flexion. So the point will not move. Patient cannot move. Okay. No movement and no flexion. So this is because of the complete fusion of the spine, which is called the bamboo spine. And what is this? Very, very important sign which is seen in the exam, which is called as the dagger sign, which is nothing but your ossification. As I've told you, the enthesitis. So this is ossification of the posterior longitudinal ligament of the spine, which is called as the dagger sign. So dagger is something this which is usually seen with the Sikhs, the Sikh religion people, they put this knife with them, small knife-like structure. So this is called the dagger. So that is called the dagger sign. Okay, that is nothing but your ossification of the ligament in the spine, and this is called as the bamboo spine. Complete fusion of the spine with the syndesmophytes is the ankylosing spondylitis, and this is a Schauber's test, which where we detect that there is no movement which is occurring in the lumbar spine by marking 2 points. Whenever you see like the chest expansion, you put the tape like this, and then when we breathe and release, the tape moves, right? Similarly, like that, we put it on the lumbar spine. We take 2 points and then we try to move the spine by bending and by flexion and extensions, and then we find there is no movement there. Hence, we take that as there is no movement and there is no flexion. That means this. Okay, that is about your ankylosing spondylitis. Treatment is again you depend upon the thing where the patient comes. You treat with the NSAIDs and you treat with other steroids, right? And sometimes you can even go for surgical thing. So osteotomies. We do osteotomies for ankylosing spondylitis, which is again a complex surgery. So that is about your ankylosing spondylitis. So we know that there is an extraintestinal manifestation. So ulcerative colitis is one which is very, very associated with ankylosing spondylitis. And here what happens is pain versus in the morning, and it improves on exercise. Okay, so there is erosion is one of the earliest sign and is associated with HLA-B12. So that is about ankylosing spondylitis. Okay, I'm tired now. Now you have to match this and let me know the answer. Muhammad Shanwaz Khan, I'm fine, thank you. How are you? So I have told you so much about ankylosis. Similarly, this is spondylosis, lysis, and listhesis. Quickly, you answer faster. Now we'll go at a faster speed. It's already 5:45. Okay, thumbs up, fine. A. Okay, I have to match, no? One. My answer is this. Nitin has answered it BAC. Correct. Me and Nitin are always right. A and A. Shri, I'm waiting for your answer. Bharat also, I'm waiting. KK, Atul, come back and answer faster. Yes. Okay. A. Bharat. Okay. Good. As we are all on the same thing, we are not going to learn much about it. So it is very, very easy. Spondylosis. Whenever somebody is telling it is losis, that means there is a degenerative changes in the spine, right? Lysis. Lysis means there is a break. Break kahan hota hai? Whenever there is a weakest area. What is the weakest area here? It is pars interarticularis. So what is the area of pars interarticularis? If you go back to spine and read, the pars interarticularis is nothing but an area which connects your vertebral body with the posterior element. So that is the weakest area. So whenever there is a break in this pars interarticularis, it is called as lysis. And this lysis will lead to listhesis. This lysis will lead to listhesis, right? So what is listhesis? Listhesis is this. How do you identify it? Now what you do, you draw a line on the posterior part of the spine like this. So now you see there is a break here. So this is called as listhesis. So if you go back, this is your S. So this is your L5, L4 and L3. So this is nothing but your L4, L5 spondylolisthesis. The upper vertebra, the forward protrusion of the upper vertebra compared to the lower vertebra is called your spondylolisthesis. Understood? Very good, Piku. And this, there is a step sign. So as you see that there is some gap here. So whenever you try to palpate the spinous processes over the clinical examination, so on the OPD, you try to palpate the spinous processes, right? So you see that there is some forward movement of the upper vertebrae, and this is called as the step sign. So step sign is usually seen in which part? It is seen in spondylolisthesis. Okay, clear? So that is about the terminology. Next, this is very important again. 45-year-old woman presents with difficulty grasping objects and complains weakness in her right hand. During the examination, the clinician tests for Fromen's sign. Very, very important. Fromen's sign. Which of the following statements about Fromen's sign is true? Okay, your answers? Okay, good. Answers for this. Hmm. Right. Nitin, you're right. Pihu, you're right. Bharat, right. Three? Good. So I think you're all very versed with all the tests. Okay, now let me test your knowledge on tests. So there are three important nerves. Median, ulnar, radial. Okay. Pen test is for pen test. Median, ulnar, radial. Pen test is for faster. Very good. Book test. Okay, this is the answer for median pen test. Median. Okay, correct. Pen test, median. Done. We are done with the pen test. Book test. Very good. Book is for ulnar nerve. Okay, good, good. Igawa. Hmm. Pointing index. Pratik. Pointing index. Three. Pointing index. Yes. Card test. Card. Hmm. Doctor, doctor. Okay. Median pointing index. Very good. Card test. Card. Yes. Wrist drop. Wrist drop. Yes. Wrist drop is radial. Holstein-Lewis fracture. Holstein-Lewis fracture will damage which nerve? Median nerve, ulnar nerve, radial nerve. Holstein-Lewis is Saturday nerve palsy. Okay, fine. Shaft of humerus, very good. Yes. So Holstein-Lewis is radial nerve. Very good. O sign. O sign. Very good. Oshner's clasp deformity. Oshner's clasp. Oshner's clasp deformity. Claw hand. Partial claw hand. Partial claw hand. Complete claw hand. Complete claw hand. Yes, very good, very good, very good. Ulnar plus median is your complete claw hand. That is why I've written here. Pihu, what do you want? High ulnar nerve, partial claw hand versus low ulnar nerve, complete claw hand. You want me to tell the difference? Yes, claw hand, partial complete claw hand is this median plus ulnar. Okay. Now tell me, in case of IGAWA test, which muscles are you testing? In case of IGAWA test, which muscles are we testing? Muscles of interossea. Again, I have to ask you which muscles of interossea. Okay. Dorsal and palmar both we are testing. Yeah, are we testing dorsal interossea or palmar interossea? Dorsal, palmar, interossea muscles is a wrong answer. Interossea is wrong answer. Are we testing the dorsal interossea muscle or the palmar interossea muscle in case of IGAWA test? Yes, very good. We are testing the dorsal interosseous muscle. And CAR test? Yes, palmar interossea muscle. Cosine is specific for which nerve? Specific for one nerve. I mean, branch of the median nerve. If you're wrong, don't no need to delete that message. That's fine. Leave it. Very good. O sign is AIN. Anterior interosseous. Okay. Very good. Pinna. Chota doctor. Pin is what? Pin is posterior interossea. Is a branch of radial nerve where you will see finger drop. In case of pin. AIN is O sign. Okay. Very good. Pin is radial nerve motor branch. Okay. Now see, this is what I have bought for you. So ulnar nerve, we are testing the book test, that is adductor pollicis, and card test is for palmar interossea, as you have answered it right. Frohman signs is where your flexion of your thumb is used instead of the adductor pollicis. That means flexor pollicis is used instead of your adductor pollicis. Okay. Next, IGAWA, we are testing the dorsal interossea. So these are all the tests for your ulnar nerve. Then radial, you have the thumb or first you have the wrist drop, that is for the extensors. All extensors are supplied by your radial nerve. So wrist drop and pin is for finger or the thumb drop. Then in the median nerve, what we have is, oh, I have forgot this, ape thumb deformity. Ape thumb deformity. You seen it? Seen in the median nerve, right? So ape thumb deformity is one where the thenar muscles are involved, and the pen test is for the abductor. So this is your pen test. So you're touching the pen like this, like this. So this is the pen test. So ape thumb deformity is something like this. So usually what happens is the thumb is perpendicular to the fingers. All the other fingers, the thumb is perpendicular. This is very specific for the humans because we can do grasping, pinching, hooking, all we can do with this hand, right? So whenever there is a median nerve palsy because of the thenar muscles, it goes back into the position of the four fingers, which is representation of the apes. That is called the ape thumb deformity. And then we have this pointing index where the flexors are disturbed, resulting in the pointing index. That is called the Osteosclap deformity or the benediction sign. So this is the benediction sign. So benediction sign, you can see that it is somewhat like this. So these two are completely closed and this is somewhat little closed, only little closed, and this is completely like this. So this is almost like the pointing index. So this is the benediction sign or the pointing index in case of your median nerve, where flexors, the long flexors, that is the flexor digitorum superficialis and the flexor digitorum profundus are damaged. And then the O sign, that both the which is the AIN, that is the anterior interosseous nerve supplies the FTP and the FPL, that is flexor pollicis longus. Understood? So that is the Kilonevin sign or the O sign. This much is enough for your nerves. Clear, everybody? Any doubts? So I just want to clear something here. When it comes to median nerve, supplies the flexors except FDP, medial half, FCU. Okay. In the hand, it supplies the thenar group, first and second lumbricals. Understood? That is the median nerve. Then you have to remember the ulnar nerve supplies the FDP medial half, FCU, your hypothenar muscles, introosseous, dorsal introosseous, palmar introosseous, third and fourth lumbric. And one interesting thing is your adductor pollicis, which is a thenar group, is also supplied by your ulnar nerve. And then comes the L, all the external. So anything which is related to thumb and the index finger, please remember that is for the median nerve, except for the book test, anything which is related to thumb and the index finger. So pointing index, ape thumb deformity, O sign, all this, thumb and index is your median nerve. And then something related to your little finger, ulnar nerve. So for example, the Wartenberg sign, where you see the Wartenberg sign, Wartenberg sign is nothing but where this little finger has gone away from other fingers. So this is the Wartenberg sign because of the ulnar nerve palsy. So something related to your little finger is your ulnar nerve. And a radial nerve, there are no tests, only remember that there is a drop. So whenever there is a drop, because it is for extension, right? But whenever there is a loss of extension by the gravity pull, everything goes down. So that is called as drop. So finger drop, wrist drop, elbow drop, all drops are your radial nerve palsy. Understood? So that is it. You have to be very, very clear. You have to read completely and then you have to answer the question. So I am happy that you have answered it really well. Next. So this is a lady presenting with morning stiffness. So once we have read it is a lady that is presenting with morning stiffness. So we are clear that this is an inflammatory disease. So we are dealing something with the inflammation, right? So we are dealing something with the inflammation. So more than 1 hour and joints in the wrist and knee. So polyarthralgia is very, very common in case of your inflammatory disease. And laboratory test, there is a positive RA factor. So there is a positive RA factor and anti-CCP antibody. So this is one of the most specific antibody antibody testing for your rheumatoid arthritis, that is your anti-CCP. Radiograph shows joint space narrowing for periarticular osteopenia. Very good. So what are the answers? So symmetric joint involvement is always there. S. Erosive changes on the X-ray. Involvement of the distal interphalangeal joints, elevated ESR. So because it is inflammatory, ESR is elevated. So there will be erosive changes on the X-ray. Involvement of the distal interphalangeal joints is the wrong answer. So the answer is involvement of the distal interphalangeal joint. So here what you have to understand is for the rheumatoid factors, so for rheumatoid arthritis, common joints involvement. So you already know that the rheumatoid arthritis is an inflammatory arthritis, right? So usually the patient presents with morning stiffness, but you have to always know what are the most important joints which are involved in RA. So the first most important is your metacarpophalangeal joints, then the wrist joint, then your PIP joint for rheumatoid arthritis. For OA, it is mainly the DIP and the PI. So distal interphalangeal joints and the proximal interphalangeal joint are very, very important. In case of psoriasis, yeah, psoriasis, can somebody answer that? Psoriasis, Shri. Yeah, that is fine. I'm asking which joints are mainly involved in psoriasis. Psoriatic arthritis, what is the most common joint which is involved? Is it PIP, DIP, wrist, MCP? Yes, very good. It is DIP, distal interphalangeal joints. Very good. Hands and feet. Okay. And then in case of gout, which joints are mainly involved? Psoriasis, it is DIP. Gout, it is that is called as MTP and knee. Pseudo gout, yes, first MTP in case of gout. Pseudo gout, it is yes, knee. And in gout, what are the crystals which are involved? Faster. Yes, pseudo gout, knee, correct. Shri, Nitin, Bharat, where are you all? Left. Gout, what are the crystals which are involved? Which crystals get deposited in the knee? Uric acid. You have to say it is sodium urate crystals. In pseudo gout, it is yeah, there are negative monosodium urate. Very good. Pseudo gout. Calcium pyrophosphate. CPPD. So these are the crystals which get involved in case of your diseases, and this will result in arthritis. So it's called gouty arthritis. It is called pseudo gouty arthritis, and then there is rheumatoid arthritis, osteoarthritis, psoriatic arthritis. Any arthritis is nothing but damage to the cartilage. So any arthritis is damage to the joint which starts with the cartilage. And now what happens is they will result in deformity. Over a period of time, they will result in deformity. So similarly, in your rheumatoid arthritis, there are two important deformities. What are the two important deformities in rheumatoid arthritis? In the hand. One is swan neck deformity. Second one, yeah, Bottonier's deformity. And then there is Z. Okay, what is swan neck? What is botaniers? Faster. So here, which is swan neck deformity? This is your swan neck deformity, right? So what is happening in the swan neck deformity? You can see that there is a flexion of the, very good, DIP flexion, and PIP there is an extension. So swan neck is, again, there are two important things which you have to remember, PIP and DIP. DIP, the swan neck goes into flexion. So obviously the PIP has to go into extension. Please remember, this is your swan neck. This is your swan neck deformity. So the PIP will go, DIP will go into flexion. So like this, goes into flexion. Then botaniers is exactly opposite to it. What happens in botaniers? What happens in botaniers? So this is your botaniers. Yes, this is what? This is hyperextension of the DIP. So DIP now goes into hyperextension. So PIP goes into flexion. Okay, just remember this particular thing, okay? So this is swan neck. So swan neck, remember DIP goes into flexion. Okay, then every answer you can do it. Okay? Fine. So that is about the various things about the rheumatoid arthritis. So mainly it is seen in the females, and usually they're present with the morning stiffness, polyarthralgia, RA factor, and anti-CCP antibodies. Okay? Anti-CCP antibodies. And now what happens is, over a period of time, the cartilage gets eroded and there will be deformity. The most important deformity which you have to remember is swan neck deformity and the botanius deformity. Okay? What is this? All of the following are commonly associated with the anterior dislocation of hip except Bharat. Very good. So the answer here is C. Perfect. So this is about your anterior and the posterior dislocation. So I have come up with a table because this is very, very important. I don't want to miss up any point. So you will go back and read. I will just explain you in detail here. So what you have to remember about anterior and posterior. So anterior is somewhat when the ball, I mean, when the head of the femur comes anteriorly, and here the head of the femur goes posteriorly. And which is the most common, anterior or posterior? Most common dislocation. Yes, Nitin, answer is right. Yes, the most common dislocation is posterior dislocation of hip. Shoulder mein which is common? In shoulder, Bharat, you left? Yes, in shoulder it is anterior dislocation. Very good. So here the most common dislocation is the posterior dislocation, and here the important thing is the attitude, because once the patient arrives in the casualty, he'll just sleep like that, right? So based upon the attitude, you can decide whether there is a dislocation. Right. So now what happens, because the ball, the head of the femur is going on to the posterior aspect. If you see on the X-ray itself, you can make out that this is coming into adduction. And here internal rotation, how you make out the internal rotation? You will make out the internal rotation based upon the presence of the lesser trochanter on the X-ray. So lesser trochanter, why it is very important? Because this is a structure, this lesser trochanter is a structure which is usually present on the posteromedial area of the femur, right? Posteromedial area. So whenever the leg is internally rotated, you cannot see the lesser trochanter, because already it is a medial structure and now you're turning the leg more inside. So now this is going completely back. So this lesser trochanter cannot be seen on the x-ray. So whenever something lesser trochanter is not seen on the x-ray, that means the limb is internally rotated. And if you can see, the femur is adducted. So flexion, adduction and internal rotation is the attitude for posterior dislocation of the hip. And now the head appears to be smaller compared to the opposite side because it is on the posterior aspect. Similarly, it is Faber. Faber is abduction and external rotation. So here if you see, the lesser trochanter will be more prominent because of the external rotation. Because of the external rotation, if you see, this is the lesser trochanter. It is neutral and it can be seen. So this is somewhat, it is not, the limb is not internally rotated. Here also you can see this is not a classical anterior dislocation. So you can see that the lesser trochanter can be easily seen whenever the limb is externally rotated. Fine. So this flexion, abduction, external rotation. So this is the attitude for anterior and this is the attitude for the posterior. And posterior, you have to be very careful because there is an important nerve on the posterior aspect. So that is your sciatic nerve, which can be damaged. On the anterior aspect, you have to be careful because there is an important artery that is called the femoral artery, which can be damaged during the dislocation. So we have already learned what is dislocation. That is nothing but there is no articulating surfaces, there is no connection between the articulating surfaces. That is the dislocation. Understood? So on the hip joint, the most common dislocation is the posterior dislocation, and the attitude which we see is the far there, and the most common complication we expect is the sciatic nerve. And what you have to treat immediately, you have to do reduction. So reduction, whenever you see a dislocation, it is an emergency because the head will lose its blood supply and may result in AVN and may result in avascular necrosis. Hence, you do the maneuver. What is the maneuver you do? You just put the patient flat on the ground, give the support. That is, you give the counter and then you flex the limb, flex the femur, that is flex the knee joint you flex, and slightly you internal rotate and then external rotate and you do the abduction. Understood? So if it is further, you do Faber, that is the thing. So whenever you do flexion, then you slightly internal rotate, so it disengages, and then you do an abduction and external rotation and it will slip back into this acetabular cavity. Right? So that is the reduction. You don't do open reduction, internal fixation. You do a closed reduction technique. There is a closed reduction technique. So whenever this technique fails, then you go for open reduction. Understood? You first go for closed reduction. When this technique is not working, when there is an associated fracture, whenever there is an associated fracture with dislocation, or when you are unable to reduce it, then you go for open reduction. Understood? Similarly with the anterior dislocation also. So these are the various features I have put up. That is the mechanism of injury, what happens usually, and then the leg, the attitude, then the most common sciatic nerve is involved and sometimes is associated with fractures as I've told you, and the most common fractures is the posterior wall fractures, and you have to always do the closed reduction. Then whenever fractures are present, you can go for the surgical open reduction. So risk of avascular necrosis is high in case of your posterior dislocation. Clear, everybody? So that is about your dislocations of the hip. Okay, quick thumbs up. Shri, Bharat, KK, Athul, Pihu, where have you gone? Clear? Okay, good. All of the following are characteristic features of osteoid osteoma. So now we are dealing with osteoid osteoma. This is very, very typical. It presents in the diaphysis, right? And it is seen again in the age group of 10 to 20 years. And this is again a bone forming tumor, and it presents as the nidus, is less than 2 centimeters. And this is very special tumor because we go for a CT scan, then MRI for identification of the tumor. So the investigation of the choice in case of osteoid osteoma is CT scan, because we want to identify bone. So whenever you want to see bone, you go for CT scan. Whenever you want to see marrow, you go for MRI. So remember, M for M. Something you want to detect on the marrow, something you want to detect about the ligaments, tendons, you go for MRI. Something you want to detect about the cortex, the bone, then you go for CT scan. Understood? Yes, investigation of choice is CECT. Very good, KK. So that is about the osteoid osteoma, and the very peculiar feature is they release prostaglandins, and this prostaglandins release can be inhibited by giving NSAIDs, which is very important for pain at night time. So that is about the osteoid osteoma. So they okay, sorry Bharat, I'm not aware that you're doing your posting also. I'm actually glad you're watching and then you're working. Very glad. I'll not call your name again. Okay. So prostaglandins, NSAIDs. So there will be pain at the night time, and we treat them with NSAIDs. And now they will have relief with this NSAIDs. So whenever you find that the patient is relieved with the NSAIDs, then this is also a therapeutic test. This is also a therapeutic test for your osteoid osteoma. Understood? It's also a therapeutic test for your osteoid osteoma. So we have clear completed. So pain worsens at night. Yes. Pain relieved by NSAIDs. Yes. Epiphyseal tumor. Wrong. Central nidus is seen. Yes. Very good. So the answer is C. Have you answered C? Very good. Most of you have answered C. Very good. I'm happy. Soft tissue. Yeah, whenever there is soft tissue, you go for MRI. So this is the nidus I was talking about. Very small. And sometimes on the X-ray, we don't even find it except for some sclerosis on the X-ray. So if this sclerosis, we have to see and we have to order for CT scan, and then we have to identify it as osteoid osteoma. So this is a thing about osteoid osteoma. And one more thing, this can be treated by radio frequency ablation. So this can be treated by radio frequency. And I've told you that this is less than 2 centimeters. If something is more than 2 centimeters, you should put a differential diagnosis. What is that tumor? Which we put as a differential diagnosis is quicker. Differential diagnosis for osteoid osteoma. Chondroblast. Yeah, you're right. Osteoblastoma. Because you're working also, no, you might be confused. So this is osteoblastoma. So differential diagnosis for osteoid is osteoblastoma also. So whenever the nidus, whenever the osteoid forming tumor is more than 2 centimeters, it is not osteosarcoma, Chota doctor, it is osteoblastoma. Okay, that is about your osteoid osteoma. Clear, everybody? This is very easy, nothing to read much about it. What you have to remember is Sprengel deformity. The Sprengel deformity is nothing but whenever you see the scapula at a higher level. So this scapula is a congenital deformity. Scapula at higher level. So this is nothing but failure of undescent of scapula. So scapula at higher level, failure of undescent of the scapula is called the Sprengel's deformity, and this is a spotter diagnosis. So they will just put up this figure and they will ask you what is it. So you will see the scapula is at a higher level and you see that there is an hypoplasia. So the scapula is underdeveloped. The scapula is underdeveloped. Bharat, come stop about those explanations. I'm not taking everything seriously. I'm not meaning it. I just like, please don't feel offended, Bharat. I'm feeling bad. You don't give explanations like I didn't read, I need revision, I'm on posting. That's fine. We are all human beings. Even I forget a lot of things. See, Shri is telling cool bro. Chill bro, it's okay. Everybody is on same page. Actually, you're answering good. I mean, like, that is why I'm calling your name. Okay, so this is hypoplasia of the scapula where you see the scapula at the higher level. Okay, the scapula is at the higher level. This is called the Sprengel's deformity, and this Sprengel's deformity can be associated with the scoliosis. It can be associated with the Klippel-Feil syndrome. Okay, so all such things. So once you see this Sprengel's deformity, you can also evaluate for these two structures. So now what is this? Surgical intervention is never required. No, no, it is required sometimes, and that is called as the Woodward's operation. It is typically present with normal shoulder, underdeveloped or elevated scapulas. Yes. So the shoulder movements can be compromised. Okay? Not the fracture of the scapula. So Springer's deformity is something where you see that there is a underdevelopment or elevated scapula on the one side. So it is also associated with the scapular hypoplasia also. So that is why you have to be careful, and this is not a fracture, and it should sometimes be treated with the surgery which is called the Woodward's operation, and they will definitely be compromised range of movements because scapula is used for upward movement, like above the shoulder movements scapula is used, so they will be compromised of the shoulder movements. Fine. Now Bouchard knots are present in which type of joint? Come on Nitin, Sri, Atul, KK, answer quickly. Mohammed, who has gone? Yes, BPHD, very good. BP and HD. So BP, Bouchard's is PIP, Herberdens is DIP. Very good, very good. So she has made it very, very clear for us. So Bouchard's is BP, that is proximal interpharyngeal joints, whereas Herberdens is distal interpharyngeal joints. No confusion. Great combination, okay? So Bouchard's is P and this is HD, that is Herberdens is distal interpharyngeal joints. So these two are usually seen in case of your osteoarthritis. So these nodes usually they see in case of your osteoarthritis, right? Understood? Next. This one, answer please. So they are talking about tuberculosis of hip joint. As we already know, tuberculosis of hip joints, there are 4 stages where the hip joint has to undergo if you're not treating the tuberculosis. So the first one, as you know, it is stage of synovitis. And the second stage is stage of early arthritis. And then there is a stage of late arthritis and stage of advanced arthritis. So whenever I say advanced arthritis, that means it is dislocations, subluxations, everything come under this stage 4. So we are all very clear what is dislocations and subluxation, right? Can you tell me one particular X-ray feature of TB hip in case of your advanced arthritis? So there is a specific name which is given to the TB hip in case of stage 4. This is 1, synovitis, 2, early, 3, 8, 4 at once. What is the typical X-ray feature which we see in TB hip in advanced arthritis? Quick. Quicker. KK? Full. Ponset? What is Ponset? Traveling hip. Where it is traveling? Wandering acetabulum, huh? You meant? Very good. Excellent, Atul. Wandering acetabulum. Second one is quick, 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 Shri. Within, quicker. There. Okay, I'm asking you one typical X-ray feature which we see in TB hip. It is motor and pestle appearance. Okay, very, very important whenever they give you X-ray of motor. Very good, Chota Doctor. Motor and pet. Siri, I'm asking you about hip and you're telling me about TB shoulder area sika. Okay. So motor and pestle appearance is seen. Motor and pestle appearance and wandering acetabulum are these two important features which we usually see in advanced arthritis in case of TB hip. So what is this wandering acetabulum? So whenever there is TB hip, what happens is there is complete, this acetabulum is like this and the head becomes so small, the head. So now because there is a lot of space to it, it keeps moving from here to here. So that is wandering acetabulum. And again, for the same reason, it appears something like this. Motor in pestle appearance is this. This we usually see in the kitchen where they use for grinding, making it into small pieces. So this is the two important things which you have to remember. So one is your motor and pestle appearance. The motor and pestle, and this is your wandering. Understood? So first stage of synovitis is where there is an inflammation. So there is a lot of synovial fluid. So this fluid needs accumulation, right? So this fluid needs accumulation and it is accommodated in the joint. So whenever something is accommodating, it should be roomy. So this is the position where the joint is roomy. Flexion, abduction, external rotation. So here where the capsule enlarges, so there is a place for the fluid to fit in. That is stage 1. And once it goes to stage 2, what happens is the synovitis sets in and there is a damage to the cartilage which will result in father. So now the limb goes in flexion, adduction and internal rotation. So this is the time where it appears lengthening. And this is the time where it appears shortening. And in stage 3, it is still in father because the cartilage is completely damaged. Now it is, the limb is shortened because of complete damage. And this is the advanced. Stage 4 is advanced. So one is wandering, one is motor and pestle. And it still stays in father. It still stays in father. And there will be, this things where you can easily rotate or move and you can feel the wandering acetabulum, right? So this is about the 4 stages of the hip. So the first stage is Faber where there is a lengthening, and second stage is father where there is shortening, and third stage is again father where it is completely shortened, and fourth stage is two things which you have to remember: the advanced arthritis, wandering acetabulum, and motor and pestle appearance of the hip and the femur. Understood? Clear, everybody? So, which is one is not there? Stage of synovitis is present, early arthritis is present, late arthritis is present, ankylosis is last advanced stage, I have told you. But there is no stage of avascular necrosis. The answer here is D. Okay? Good. Okay, Klippel-Feil syndrome is it is a straightforward. So this is your spot diagnosis. What is this? This is your Klippel-Feil syndrome. What is this syndrome is all about? It is nothing but what is the pathology here? See, what is the pathology here? So, there will be fused cervical vertebrae. So, unfragmentation of the cervical vertebrae. The cervical vertebrae should be, in 1, 2, 3, 4, 5, 6, 7, 8. They should be individually present, but they will be unfragmented. So, there will be fusion of 1 or 2 cervical vertebrae. This fusion of the cervical vertebrae will result in 3 interesting features, which is called as the short neck, low posterior hairline, right? So these are the important things which you have to remember, and fused cervical vertebra. And short neck, low posterior hairline, and fused cervical vertebra will be present, and they can be associated with scoliosis also. They can be associated with scoliosis or the springel deformity, like the scapular deformity. So, low posterior hairline, short or webbed neck with fused cervical vertebra is called the Klippel-Feil syndrome, and fusion of thoracic vertebra is usually not seen. So, the answer is fusion of thoracic vertebrae. Okay. Clear, everybody? Klippel-Feil syndrome? Yeah, Shri, that the third, the triadic, there will be restriction of the movements, restriction of the cervical movement. But it is associated with the scoliosis and also the springel deformity. So, fusion of thoracic vertebra is usually not seen in case of your Klippel-Feil syndrome. Understood? What is the following radio resistant tumor? So this is not typically an orthopedic question. It could be an integration of radiology, surgery, and orthopedic. So I have told you that radio resistant is mainly which we have discussed before. Yes, she is right. Osteosarcoma. So radio resistant is osteosarcoma. So these are the radio-resistant tumors. What I want you all to remember is my thing, that is osteosarcoma. Rest is up to your general surgery teacher. And here radio sensitive, I want you to remember the Ewing's sarcoma. So the most important radio sensitive is Ewing sarcoma. It is usually described in book as it melts like snow on radiation. That is the description given to the Ewing sarcoma, and radio resistant is osteosarcoma. I don't want to leave such, easy and one-liner, so that, you don't need to put a lot of brain. Just remember that radio resistant is osteosarcoma, radio sensitive is Ewing sarcoma from orthopedics point of view. Next, match this faster. Involucrum, sequestrum, cloacae. Quicker, quicker. Okay. So the answer is B. We are in good terms, Mohammed. Okay, Shri, Nitin, right? KK, Atul, where are you? Pihu, Ashish has just joined. Okay. So see, involucrum is nothing but we all know that there are three important terminology which you have to remember in case of your osteomyelitis. So the first one is supposed to be the sequestrum. Sequestrum is nothing but this is a dead bone. This is a dead bone. So dead bone is something there is no vascular supply to it. So there is a cutoff of the vascular supply. So whenever there is a cutoff of the vascular supply, there is no resorption of the bone. So the bone appears sclerotic. So whenever something is sclerotic, we call it as dense white appearing bone on the X-ray. And this dense white appearing bone is always surrounded by the granulation tissue that is lucens. So something is alive, granulation tissue is lucent, right? So that is called the lucency. So something is surrounded by lucency, a dense structure inside is called vestrum. And the new bone which is formed over that is called the involucrum. Involucrum is nothing but the new bone. Involucrum is the new bone. Involucrum is the new bone. And then the openings, okay? The openings or what do you say? This opening on the bone, this is called the cloaca. The opening or the sinuses which connect your sequestrum to the surface of skin, this is called as cloacae. Understood? So the sequestrum is the dead bone because the bone is dead inside. So this is called the sequestrum, that is the dead bone. Then you have the granulation tissue, which is that is present, and the new bone which is formed is the involucrum, and the discharging sinus is called the openings is called the cloacae. So the infection which is there inside will come through this cloacae onto the surface, and this is nothing but bony spicule. So whenever you say a discharging bony spicules, you're very sure the osteomyelitis. So the discharging sinus here is the bony spicule. So the discharging sinus here would be your bony spicule. Okay. So the answer here is C, A, and B. Very, very clear. Osteomyelitis, important again. Okay. What is the answer for this? Following test used to diagnose the carpal tunnel syndrome. Very, very important. Answer for this, Atul? Nitin? Yes, very good. The Phelan's test. So what is Addison test for? Addison test is for faster. So the answer Phelan's test, I've got the answer. That is Phelan test. Now I'm asking, what is the Addison test for? Very good. Thoracic outlet syndrome. Perfect. So thoracic outlet syndrome is your Addison's test. Then what is Allen's test? Thoracic duct. Can't check for your answer. What is the duct? Allen's test. Good. Atul, Nitin, Chota Doctor, everybody good. Allen's test is for radial nerve. Allen's. Yeah, patency of the radial artery. So usually they test for patency of the collateral, that is radial and ulnar. Okay, so that collaboration of the radial and ulnar over the wrist, they test for the patency of radial and ulnar. So that is called the Allen's test. What is the Ober test? Ober test? For ABT sampling, they'll test for Allen's. Huh? QL band. These are the test names which you have to remember, okay? Iliotibial band, Ober's test, Allen's test is for patency of the radioulnar collaterals, and then Addison's is for thoracic outlet syndrome, and Fallon's test is for carpal tunnel. Then Durkin's test, Durkin's test is for yes, carpal tunnel syndrome. Very good. Tunnel sign, tunnel sign is for yes, Durkin's is CT. Yes, carpal tunnel syndrome. Tunnel sign is for